This session, Just Cases, is an interesting session about clinical presentations, which is the backbone of all clinical learning. And so we will be enjoying almost 17 presentations by our guests, by our speakers. I invite our first speaker, Dr. Subhash Dande. He will be giving us practical tips on IDS.
So, very good morning to one and all. Slides. So, basically, IDS is most common type of the strabismus. These are the various clinical photographs of various patients who presented with IDS. So it is one of the most common type of the strabismus. So basically in IDS patients, this was 9-year-old female, and this is case of IDS with poor control, and PBCT was 30 prism diopter and 40 prism diopter for near and distance. Vision was 6/6. So in these sort of patients, we only do horizontal surgery, that is recession resection. This is post-operative photograph of the same patient on day 1. Then another category of IDS is decompensated IDS with V pattern, in which there is no inferior oblique overaction. So this was another patient, 20-year-old female. Vision was 6/6 in right eye, other eye was 6/60. And the PBCT for near was 30 prism diopter, for distance was 45 diopter. Since in this patient there is amblyopia, so the classical teaching is amblyopia has to be treated first, followed by the surgery. So this patient was given occlusion therapy, and it was followed by surgery, that is recession resection. And since this V pattern is without inferior oblique overaction, so we have to do the muscle transposition in this sort of patients. This is post-operative photograph of the same patient on day 1. Then third category of the IDS is, there is IDS, there is poor control, there is presence of V phenomena, and this V phenomena is due to oblique overactions. So in these sort of patients, we have to tackle the inferior oblique muscle. So basically this was 11-year-old female. Vision was 6/9 and 6/6. PBCT was 50 prism diopter. Patient underwent surgery, recession resection, plus since inferior oblique overaction was also there, so inferior oblique recession has been done. And you are seeing V pattern is there here. And this is post-operative photograph of same patient on day 1. Then another category is infantile exotropia, and this sort of the patients, they should be operated at the earliest. So basically we see only these 4 category of the patients in IDS, and there are a lot of other things which are controversial in the IDS. when to measure the deviation, whether you go for orthoptics or surgery, what is the age of surgery, amount of surgery, type of surgery, unilateral or bilateral, what is the role of lateral incompetence, prism adaptation test, and refractive error, and management of pattern strabismus. So basically, in these sort of patients, there are two schools of thought, whether you want to operate before 4 years or after 4 years. So basically, whenever you are able to measure the deviation comfortably, you should operate. Secondly, goal of surgery is plus minus 10 prism diopter of the orthophoria. If there is one eye is amblyopic, then essentially you have to do the surgery in that eye, but if there is divergence excess, then you can go for bilateral lateral rectus recession. And if there is presence of pattern strabismus with V phenomena, then if there is no oblique overaction, then you have to do the transposition, and if there is oblique overaction, you have to do the recessions. Thank you.
Thank you, Dr. Subhash. Any comments from the audience? Now we will go on to our next speaker, Dr. Abhishek Anand. Dr. Abhishek Anand. So without wasting time, we will go to our third speaker. We'll invite him, Dr. Anand later. I invite Dr. Love Koshgave, for his interesting talk on the unpredictable pediatric traumatic cataract, winning the surgical battle. May I request the chairpersons to come on the dais and take the seat?
Thank you, and good morning to everyone. It's a pleasure to come to Ranchi after a long time, and I will show few cases of traumatic pediatric cataract. And in this case, what you see is there is a self-healing corneal wound which has been due to a trauma a few weeks back, and that was not repaired incidentally. So we decided to go ahead with cataract surgery, and in this there was a pre-existing anterior capsular tear which was enlarged using a 23 gauge cutter, and so that we get a respectable anterior capsular opening through which a lens can be implanted in the bag. As far as possible, we should aim to implant the lens in the bag in these cases. And after the IOL implantation, what you will see is it's quite well centered because the bag was there, and in the process the the wound, entry wound started leaking, which was sealed by a single 10-O nylon suture. So this is the first case. And after that, the posterior capsular access was done using a cutter. Care has to be taken that the there is no visual axis opacification, and the anterior chamber formed with air bubble. So one good thing about traumatic cataracts is that most of the cases behave differently, and we have to have a different kind of approach for every case. This was an old blunt trauma with a fibrosed anterior capsule, and in this the care was taken to not to cover the fibrosed area during capsulorhexis, but as you can see, at one point it will not proceed further. So there is no point pulling it and causing stress in the zonules. So we stopped there, and the rest of the capsulorhexis was done using a cutter. And with 23 gauge cutter, you get a relatively smooth margin, not ideal as a manual capsulorhexis, but the good thing is that it will not extend because of the fibrosis, and if you have a large opening in the anterior capsule, then the lens can be comfortably placed in the bag without causing extension of the capsulorhexis margin. And here it's being trimmed to get a proper size. The anterior, the cortical aspiration is done, and after which the lens is implanted in the bag. So this is another scenario in which of traumatic pediatric cataract, and most of these trauma cases are children. Very few adult cases you will get in a similar scenario because children are more prone to injury. Lens placed in the bag, and posterior capsulorhexis anterior vitrectomy done using a cutter. So this is the pre-op and post-op picture of the same patient. Another case in which there was an entry wound in the cornea, and when we started there was a opening in the anterior capsule, and when we started we could locate the foreign body in the anterior chamber. So that foreign body, as you can see, it has been left there, cortical aspiration done, and through the main port slowly the foreign body is removed from the anterior chamber, and rest of the surgery is similar to what we had done in the first case. The capsulorhexis opening, the anterior capsular tear was opened and enlarged, and cortical aspiration done, lens placed in the bag. So most of these cases, if you do it properly, you will be able to implant the lens in the bag. And this is the pre-op and post-op picture of the same patient. So this is another case in which there is a traumatic cataract with posterior synechia and fibrosed anterior capsule. So the pupil is enlarged using the hooks for proper visualization, and capsulorhexis must be attempted in these cases because the non-fibrous part will make a good opening, and the fibrous part we can always use a cutter to enlarge. So through the non-fibrous part a small capsulorhexis was done, cortical aspiration was done in this case, and then the capsulotomy was enlarged using a cutter, and lens implanted in the bag. I think there will be one more video and then I'll stop. Then as you can see, when the posterior capsule is fibrosed in this case, and with the cutter you can very easily demarcate that the visual axis opacification is gone, and and eventually this child also did well. This is the pre-op and post-op picture. Now, in a blunt trauma, many times we'll get a pre-existing posterior capsular defect, and the picture of that will be quite clear when you see the child. If the child is not cooperating with slit lamp, in the microscope only you will be able to make out a pre-existing capsular posterior capsule defect. The trick there is don't do any hydro procedure before cortical aspiration, and as you can see, after the cortical aspiration the vitreous prolapse could be identified, and in this case also, since it was a spindle shaped posterior capsular opening, we could implant the lens in the bag, after which the posterior capsular the visual axis was cleared of posterior capsule, anterior vitrectomy done, and this is the pre-op and post-op picture of the same. I think I'll stop there. Thank you so much.
Thank you, sir. We are very much in time. Any questions from the audience, please? So we move on to our next speaker, Dr. Rishi Swarup. He'll be speaking on combined DSEK and SLET for case of Munchausen syndrome by proxy.
Thank you. So this is an interesting case. I hope you enjoy and learn something from it. इसमें कौन सा है? ठीक है, कोई प्रॉब्लम नहीं. हाँ, ये वाला? Okay, so this was a patient who was a 75-year-old female patient who had come to my OPD a couple of years ago. She had complained of decreased vision, redness, watering in both eyes since 2 weeks, sorry. She had had a cataract surgery elsewhere 2 months ago in the right eye and left eye 2 years ago. The patient was, by her operating ophthalmologist, put on Predfort hourly, 2 hourly, chloramphenicol eye drops 4 times a day, and patient was complaining of intense burning, especially after instilling of eye drops, and I got a history that the drops were instilled by her daughter-in-law. On examination, this is what each eye looks like. You can see there is a epithelial defect in the right eye, inferonasally, and the left eye there is a large epithelial defect involving the entire cornea, and there is also a defect in the conjunctiva inferiorly. And the whole eye is very intensely inflamed and edematous. Now, there is also a lot of pigments on the endothelium in both eyes. So I am not 100% sure what I am dealing with. The corneal sensations were equivocal, not clearly negative or positive. So I was thinking that we are dealing with a case of Munchausen syndrome by proxy. Munchausen syndrome is when you cause self-harm, and when somebody else does it for you, it is by proxy. Okay, so I am thinking that the daughter-in-law is instilling something wrong into her eyes, maybe acid or something. So I asked for the bottles, but somehow the relatives did not provide the bottles to me in spite of repeated asking. And so this is just an assumption that I made. The other possible differential diagnosis was a drug toxicity or a viral keratouveitis with the neurotrophic keratopathy, or a mucus swishing syndrome because of the inferior conjunctival defect. So these are all other possibilities, but this was the one which was really fitting into the diagnosis in my opinion. So I decided to stop all the previous drops, just put the patient on preservative-free lubricants. By day 2, the epithelial defect of the right eye had started contracting and the left eye was status quo. So we decided to do a temporary tarsorrhaphy in the left eye to aid the healing of the epithelium. So this is how the patient looked like on day 10. You can see this epithelial defect of the right eye is contracted, but in the limbal area it's still there. Left eye tarsorrhaphy was in place. The conjunctival defect had completely healed, but the epithelial defect was still persisting, and there was lots of edema and pigments on the cornea. And tarsorrhaphy was in situ, as you can see. So by day 13, I put a bandage contact lens in the right eye, and left eye we decided to do an amniotic membrane graft because the epithelium was refusing to move. By day 20th, the right eye had completely healed, the epithelial defect had closed, and the left eye, the amniotic membrane had become integrated into the epithelial defect, and you can see there is vascularization coming in from the sides. But the epithelium had closed and the amniotic membrane had joined in. So by day 50, which is 1.5 months, right eye stroma started clearing and the eye started looking quieter. The left eye, the AMG had got integrated. There was like a limbal stem cell deficiency. You can see these vessels coming in like a pannus and some scarring. But there was no epithelial defect. Day 75, another 25 days later, right eye is still little better, but left eye has developed a total limbal stem cell deficiency with a persistent epithelial defect, as you can see here. So basically this eye has gone into a stem cell deficiency, plus the whole stroma is edematous. So this cornea has endothelial as well as a surface problem. By day 90, right eye is almost status quo. Left eye we decided to put an amniotic membrane graft and a tarsorrhaphy once again to try and heal that epithelial defect. By day 110, which is almost now 3 months after the first insult, the right eye is clearing further. Left eye, the amniotic membrane has got integrated. Tarsorrhaphy is in place. By day 150, which is almost 6 months now, the right eye shows healed cornea with mild scarring, Best corrected vision in this eye is 20/50. Patient is pretty happy with the vision. But left eye, you can see the whole cornea has now got a complete stem cell deficiency. There's a pannus on the cornea. Plus on the slit, you can see there's a retrocorneal membrane, and the whole cornea is edematous. So we are dealing with the endothelius as well as the surface failure in the left eye. Now, patient is happy with the right eye, but also wants to see in the left eye. So we decided to do something which will correct both the endothelium and the surface. And this is the first reported case of a SLET procedure combined with the DSEC. SLET is a surface stem cell transplant. This we have reported and published this case as well. So you can see we took a limbal biopsy from the fellow eye, as you can see in the video, and then this was then sent to the broken into small pieces and then transplanted to the other eye. So we removed the pannus from the unhealthy eye, and after removing, you can see the stroma is reasonably clear. And then we did a DSEC procedure in which we put an endothelial lenticule inside. After the DSEC was attached with, lenticule was attached with air, on the surface of the eye we put an amniotic membrane graft, and on the surface of the amniotic membrane we stuck small explants of that limbal biopsy we took from the fellow eye, small bits, which is called a simple limbal epithelial transplantation. So there's a DSEC graft inside and a stem cell graft on the front. This is how the patient looked after day 200. You can see that the cornea had started clearing. And by day 240, the visual axis is nicely cleared up. And by 1 year after presentation, this is how the eye looked. Right eye and left eye looks almost identical. The surface has healed, the stem cell deficiency has gone. And there's mild scarring in both eyes, and both eyes were about 20/50 best corrected vision with glasses. Patient is quite happy with the vision. So even in bad cases, if you're persistent and you do the right things, you can manage. And this was just to show that surface procedure and endothelial transplant can be combined. Finally, I'd like to make an appeal to support me for member scientific committee. I'm contested number 28. Elections start on 23rd of February. Thank you.
Thank you, Dr. Swaroop. Any discussion? So now I invite Dr. Arvind Kumar Maurya for his talk on amblyopia management in adults using orthoptic. Dr. Arvind Kumar Maurya. So we move on to the next speaker. I invite Professor Shalini Mohan. So now I invite Dr. Ankur Singh. Ankur Singh. May I invite Dr. Ajay Kumar Gupta for his talk on toric ICL surgery, both eyes.
Good morning to all. I am going to present on the topic of toric ICL surgery, which I did 7 months back. So any surgery which is you perform in any young patient, especially 22, 23-year-old, and if you get any problem during surgery, it's a very nightmare for you. So ICL surgery, the history, the first ICL was performed in 1993 and it got FDA approved in 2005. And 2020, just 7 years back, the STAR innovative presbyopia correcting implantable collimator lens was approved. And EVO ICL, its toric version came in March 2022. So I am showing you surgery. The pre-operative prescription you can see, and the Loading of lens is very important in ICL surgery. It is very important to not to pull the cartridge. In spite, you have to pull the lens to the designated position before pushing the lens, loading the lens inside the eye. So, in spite of pulling from the forceps, you have to withdraw your hand and just hold the lens. I am pushing the cartridge, not the lens. Pulling the cartridge, sorry. So toric lens, you can see the marking where I have to align the lens at the 180 degree, 180 degree. So after delivering the lens, what I noticed that lens is in a invert position, means it is upside down. So that you can see the mark here, it should be on the opposite side, but it came on the right side. It should be on the left side. So I tried to remove the lens, but due to fear of break, I attempt to remove the lens, but it was not possible, and I couldn't have any backup lens, and on multiple attempt I was not able to remove the lens in toto. So what I did, what we should not do, I revert the lens inside the AC. So you can see the, so I revert the lens and aligned in the proper axis. So Dr. Kashyap sir told me that whenever you insert a toric lens, better to insert in the AC, align it in a designated mark, and then you tuck inside the, because there is always fear of damage of zonule. So you should not rotate after tucking the lens, so it can damage the zonule. So now it is the properly aligned, and this is the surgery of other eye. So I am skipping this part because already one eye we have covered. So post-operative follow-up, you can see the clear cornea, and it's a right eye, and left eye. So I did a specular microscopy to see the status of endothelium. It was okay. And so take home message is toric ICL can be excellent alternative, not eligible for LASIK, especially those with high astigmatism. And careful lens loading is very important, and we should do specular microscopy before and after the surgery, and counseling of the patient is very important. Thank you.
Thank you, Dr. Ajay, for sharing your experience. Any questions from the audience? Thank you, Doctor. Now I invite Dr. Malay Verma to share his experience on sibling of Marcus Gunn. Dr. Malay.
Good morning, everyone. I hope everybody had a good night of sleep after yesterday's party. So, this is a story of two conditions looking almost like each other, but quite different from each other also. So this was a 68 years old male. He was referred for management of Marcus Gunn phenomena with complaints of right eye becoming small or winking on opening of mouth. And the onset was since 1 year, gradually onset. And on examination, the right eye upper lid was drooping on opening the mouth. The levator action was excellent and minimal ptosis was seen, but otherwise the whole eye and everything was unremarkable. You can see the picture, one with the eyes, one with the jaw open, one with the jaws closed. Now, what is Marcus Gunn jaw winking? It's present since birth, and it's an abnormal connection between two nerves. One is the trigeminal nerve supplying the pterygoid muscles of the jaws, and the oculomotor nerve supplying the levator muscle that lifts up the eyelids. So pterygoids, they open jaws, and LPS lifts the eyelid. So jaw movement causes widening of palpebral fissure. But here something is not right, because if you see in Marcus Gunn jaw winking, there is opening of the eyes, widening of the eyes on opening the mouth, whereas in this case, when the patient was opening the mouth, the eyes were becoming small. So, and also since it was not present since birth, and the patient then on further questioning revealed a history of facial nerve paralysis 2 years back. And the eyes were narrowing instead of widening, which is commonly seen in Marcus Gunn. So this was a case of Marie-Nemat syndrome, also called as inverse Marcus Gunn. So inverse Marcus Gunn, it is seen in cases of aberrant regeneration of seventh nerve, and there is an abnormal synkinesis between the pterygoid and orbicularis muscle. Orbicularis muscle, it closes the eyes, whereas levator muscle opens the eye. That is why in inverse Marcus Gunn, there will be narrowing of eye instead of widening of the eyes. So injection botulinum toxin 15 IU was given on these sites, and patient did not come for follow-up. Either he was not happy with the treatment or not happy with the charges, whatever. So this is the short cases. So, thank you.
Thank you, Dr. Thank you, Dr. Malay. The case is open for discussion. Any discussions, please? Now we move on to our next speaker, Dr. Nilesh Kumar, to share his experience on premium IOL in pre-existing PCR. Stick to the basics.
Yes.
वो आ रहा है क्या? आ तो रहा है। नहीं नहीं, हाँ वही वीडियो था, वीडियो। हाँ अभी आया। हाँ वहीं से प्ले कर दीजिए। So, good morning everyone. Thank you JHOS, Bharti ma'am, BP sir for inviting me. It has been a wonderful conference. So, I'm going to talk on premium IOLs in not only pre-existing PCR. There is first case that I'll show is an iatrogenic PCR actually. So this is a hypermature cataract, white cataract, and when I am just doing, can we एक बार start कीजिएगा ना फिर से? So when I start the rexus, it runs off, and what major blunder I do is, instead of trying to pull it back, I cut it and then start, and then there is a free tab that is over there, and this is a very hard nucleus, a brown nucleus that is there, with patient having IFIS, shallow AC, all kinds of issues that can happen, and I do the cortical shaving. When I take out half the nucleus, what I see is the nucleus has stopped moving. It is not moving as freely as it should, and there is a PCR that is behind. So at that time I stop, just move it aside and see, and at that time there was no flutter there, and this patient is a ward commissioner and she wanted a trifocal only, nothing else. So I thought that let me try. I tried to do an IOL scaffolding with that. The trifocal went inside. Both the haptics in the back, because the PC was not, the vitreous was not disturbed, and then I started to do everything in middle. You see the pupil is very small, there is nothing else. So here I am utilizing the basics of Phaco, that is the central safe zone. I am not moving here and there, doing what is necessary only in the central zone, minimal of manipulation, so that this doesn't collapse, nothing else happen. So now once the nucleus is out, you see there is a cortical matter that is behind. I again thought that I should leave it and do a YAG caps later when the things get stable. But again I thought that let me try the PC, the vitreous is not disturbed yet. Let me try to see if I can go behind and get it out. So I just went, this is the visco cleaning from above, and then I just try to go behind the PC. Behind the IOL. So just stop the irrigation and then restart it, and I am seeing that the vitreous, the flutter sign is not there, so it means the posterior hyaloid phase is intact. So then I switch my hand and go with the aspiration port behind and do a gentle aspiration of that cortical matter. And with that, the central area becomes clean, so that the next day patient is good. Luckily, this patient is still 6'6" and 6, 2 months of follow-up, and came for the second eye. I was just praying that this lens doesn't dislocate, and it has not. And that is the thing, that when you are seeing the basics, when the PC, the posterior capsule rent edges are not fluttering, it means the posterior hyaloid phase is intact. That won't extend, and it will remain stable. So that is one thing. Can we play the other video? Yeah. So this is a case where it was a traumatic cataract, again pre-existing big rent that is there, but luckily it was 2 months old, so you can see the edges are fibrosed. Meanwhile I am doing it, you can see the anterior vitrectomy is already being primed. So we have to be ready, otherwise what we lose as a precious time in such cases is when we need anterior vitrectomy, the attendant is searching for the anterior vitrectomy set and everything, and that precious time makes the thing go worse. So everything needs to be ready beforehand. Again, multiple visco delineation. I don't do hydro in this because hydro I feel is more unpredictable. It can go behind and go into the piece behind the posterior capsule. Visco is much safer. Very slow Phaco aspiration, not much of energy being used, or trying to use the machine's vacuum to get out everything. Again, the same principle of basics, that be in the center, don't go to periphery and try to pull out everything. Be in the center, and whatever you can see, that only you grab. So now I see there is a place from where the fluid can go behind and extend the PC rent. So at this time what I do is go at that place, put some visco-dispersive agent there, and then take my probe out, and then again go through the main wound. I'll go through the main wound and do the same thing. I'll try to go through that and make a scaffold kind of thing with that visco-dispersive agent. And now very slow and very clock hour by clock hour, the cortical matter I'll aspirate through this. Again, this case, a young patient, 19-year-old, wanted to be glass independent because only one eye was having traumatic cataract and wanted, so he wanted a trifocal, but I told that trifocal is very risky for you. I'm not sure. Let's try for a plate haptic EDOF because that will give some more stability to you. So a plate haptic EDOF from Zeiss has been planned. So now you see that because of the fibrosis, the PC rent has not moved at all. So again, an in-bag implantation is being done. Very stable. The patient is around 2.5 months of follow-up, to 3 months of follow-up, 6 and 10 unaided. Gentle visco wash is being done, and the moment I see that there is some chance of some vitreous that might come, I stop. I leave some visco behind. It is not. It doesn't matter. We can take care with Dimox and topical acetazolamide. Topical anti-glaucoma agent. Before coming out, I do a fluid air exchange in AC so that the AC doesn't collapse. Otherwise, what happens is when we take out the irrigation, and at that time AC collapses and the vitreous can come out. So before getting the irrigation out, I do a fluid air exchange and make the AC stable. With this, a little bit of carpinol, and the case was closed. So thank you for.
Thank you, Dr. Nilesh, for your sharing your valuable experience. Anyone wants to have any question? No, can I take a pause and with your permission of the audience, may I repeat the name of our previous speakers if they are present? So our next topic is refractive predictability and visual outcomes of cataract surgery following corneal refractive surgery. May I invite Dr. Smriti Kumari for this?
A very good morning to one and all. I'll be presenting on refractive predictability and visual outcomes of cataract surgery following corneal refractive surgery. So I have no financial interests. This was a case of 62-year-old male who presented with chief complaints of progressive blurred vision in both the eyes for past 2 years, worsened right eye and difficulty during driving. He also had the complaint that he cannot see the road signs despite wearing glasses. So he had a history of LASIK in his left eye performed 18 years ago for high myopia, and the medical records were not available. So the current status was he had dry eyes, which was controlled by the artificial tears, and the hypertension was controlled, no diabetes, and these were his external findings. So as you can see, there has been a considerable rise in the prevalence of cataract surgery post-refractive procedures, and studies have shown that less than 70% of the patients with the cataract surgery post-laser refractive surgeries, they are able to achieve a target emetropia within plus minus of 0.5 diopters, whereas it is 80% of the virgin eyes. So if you look at the challenges that we face in the cataract surgeries after corneal refractive surgeries, it's because of the altered corneal curvatures and because of the refractive surprises like hyperopic surprises, and because the patients has very high expectations as they demand a complete spectacle independence as they had previously after the cataract refractive surgery. So visual performance is affected both by qualitative and the quantitative factors. So it's not only important to correct the lower order aberrations like myopia, hyperopia or astigmatism, but it's also important to correct the higher order aberrations which are going to manifest as glares, halos, starburst and ghost images. And for this you need to go for a wavefront analysis, and studies have also shown that there is a direct correlation between the tear film and the higher order aberrations. So this highlights the importance of tear film optimization to allow for maximum performance of the monofocal and advanced IOLs. And here you can see the high myopic patient who are highly susceptible to the positive spherical aberrations. So in cases of multifocal candidates or patients who are wanting premium ILs, the total higher order aberrations, they should be less than 0.3 micrometers. Now, there are challenges in the IL power calculation, like you have the index errors. Because keratometric devices, they measure the paracentral area and central true flat K is not measured, and thereby you get a false high K because post-LASIK and post-PRK, the anterior corneal curvature has been changed, and this is the reason for the false high K. If you look at the device errors, the standard keratometric index of 1.3375, they are based on the constant anterior and the posterior curvature ratio, whereas post-LASIK or post-PRK cases, you have the alteration in the anterior corneal curvature, whereas in RK patients, you have alterations in both the anterior and the posterior curvature. So this results in these a different index of keratometric index. So in the formula errors, the Virgin's formulas, they use axial length and K values to estimate the effective lens position. Post-operative ACD remains the same, but because the K values have changed, the effective lens position also changes. So therefore, it's very important to go for a meticulous preoperative workup and diagnostics with a detailed refractive history regarding the type of procedure that has been done, ablation, magnitude, optical size, and very important is the ocular surface optimization, because you need to treat aggressively your DMD, DEDs, dry eye disease, or the meibomian gland dysfunctions before your final biometry, and corneal tomography in form of pentacam, OPSCAN analysis, for the total corneal part, the posterior corneal astigmatism and equivalent keratometric readings has to be taken into account. Another important thing is you have to go for your macular screening, because you need to rule out any pathology, any occult pathology that is going to actually limit your visual potentials. And advanced biometry in form of your IL Master 7N can be used for total keratometry. And target strategy planning is very important. You need to target slight myopia, like minus 0.25 to 5.5 in post-myopic LASIK eyes. Now, IL power calculations can be done by the ACRS calculators and advanced formulas, and the evidence-based selection, if you go for Parrot 2K, demonstrates improved accuracy in post-LASIK eyes with 73% achieving plus minus 0.5 diopters, whereas it is only 54% with the traditional methods. These are the comparative data using the modern IL calculation method, improvements with the modern IL calculation methods. In the IL selection strategies, it's very important that if the patient is myopic LASIK patients, then we have to prefer or go with negative or neutral spherical aberration ILs. For hyperopic ablation patients, you need to go for zero spherical aberration ILs, and for premium ILs, and EDOF ILs can be tried, toric for astigmatism correction. To conclude, precision and personalization are the key. So you need to go for a meticulous assessment, go for tailored calculations which combine the pentacam posterior corneal data with the ACRS calculators and modern formulas, because they significantly improve the refractive predictability and the surgical outcomes. And enhanced outcomes can be achieved by emerging technologies, including the adjustable IOLs, light IOLs, and AI-driven biometry. Intraoperative aberrometry is a very promising tool for continued advancement in the visual outcomes in patient, and we always aim for continuous refinement to meet the growing patient expectations. So always under-promise and over-deliver. Thank you.
Thank you, Dr. Seema. Now we move on to our next topic, varied atypical presentation of ocular TB in West Singhbhum region. May I invite Dr. Reena Kumari for this?
Atypical. हाँ भैया. हाँ. Good morning, everyone. Today I am here to discuss atypical presentation of ocular tuberculosis, and which I have seen in ESI Hospital, Adityapur, under West Singhbhum. As we all know, ocular tuberculosis is a rare but important extrapulmonary manifestation of tuberculosis. 1.4 to 5.7% of tuberculosis cases show ocular involvement. Based on the WHO Global TB Report 25, India holds the highest global burden of tuberculosis, accounting for 25% of the world's tuberculosis cases. So ocular tuberculosis cases are also high, ranging from 0.4 to 9.8% of total ocular inflammatory diseases. Jharkhand is considered a high burden state for tuberculosis. The disease disproportionately affects the state's significant tribal population, and so the East and West Singhbhum districts with level difficult areas. My first case is a 51-year-old male patient who came to me with sudden diminution of vision for 4 to 5 days in left eye and pain and redness for 7 days in left eye. His history was recurrent episodes of pain and redness for 2 months. Past history was patient first developed ocular symptoms around 9 years back in 2015 as bilateral stromal haze plus pain and redness left eye, treated with oral and topical steroids. He had 3 such episodes during this period, and each time he was diagnosed to have left scleritis and was treated accordingly. When patient came to me, his vision was 6.6 in right eye and 1 meter finger count in left eye. IOP was normal. On examination, congested left superotemporal quadrant with stain negative stromal keratitis along limbus 11 to 3 o'clock position in left eye and 11 to 1 o'clock position in right eye. AC was silent. On fundus examination, media was clear. Blurred temporal disc margin with obliterated cup was seen. Well-defined horizontal chorioretinal folds were seen. Treatment was given to him was oral and topical steroid with ACV 3%. This is the picture showing corneal haze, and OCT showing folds in retina. MRI was done, thickening of posterior and lateral wall of the left eyeball displaying hypointense signals. On T1 and T2 weighted images with mild hyperintense fluid was seen around the left eyeball, and mild intraconal left retroorbital fat stranding was seen. These are all suggestive of posterior scleritis with inflammation. Lab investigations were done. Serology was negative, ESR raised, CRP was normal, Montauk's test was positive, and quantiferon gold IGRA was positive. X-ray chest was normal. This is the MRI report of the patient. He was given ATT plus oral steroid and topical steroid. Vision improved within first 2 to 3 weeks. Patient completed 9 months of ATT course. Now vision is bilateral 6.6, corneal opacity reduced, no recurrence of redness, and minimal episode of mild pain off and on. Post-treatment MRI was also done. Bilateral eyeball appears normal in shape, size, and contour. No hyperintense fluid around the eyeball. Intraconal retroorbital fat is also within normal limit. This is the post-treatment MRI report. Case 2 was 42-year male who presented with diminution of vision for last 12 to 15 months in both the eyes, left more than right. His history of presenting complaint is very long. When he came to me, his vision was 6.9 in right eye, 6.9 part in right eye, and 6.60 in left eye. Anterior segment was normal, media was clear. On fundus examination, right fundus has had healing multifocal serpiginous like choroiditis and left multifocal active choroiditis. Serology was negative, CRP was normal, ESR was raised, Montauk's test was positive, and IGRA was negative in 24, but was previous reports when reviewed was found that IGRA was positive in 23, but patient had not taken ATT. Physician consultation was taken and ATT was advised. The patient was put on ATT plus Visolone tablet and Nepafenaic eye drop. After treatment, patient's vision improved. Now his vision with glasses in right eye is 6.9 and left eye 6.12 partial. This is the OCT report after treatment. Before starting ATT, patient had frequent recurrences even after taking oral and IV steroids along with posterior subtenon triamcinolone acetate, intravitreal razumab during the first year of illness. After starting ATT, patient didn't need systemic steroid except first few weeks. Another case was 39-year-old male presented with left lower lid chalazion and unhealthy lower lid margin. Chalazion was not a single lesion, it was 3 and matted from inside. Incision and drainage was done in microscopy and histopathological examination was positive for tuberculosis. ESR was raised, Montauk's test was positive, X-ray test was normal. He was also advised ATT. This is the picture showing the unhealthy margin of lower lid. Many more cases came to my center, few with recurrent anterior uveitis, recurrent episcleritis, retinal hemorrhages, marginal keratitis, and vasculitis. All these cases are diagnosed within 1 year. Though all these ocular TB cases have varied presentation, it may be concluded that ocular tuberculosis is much more prevalent than what we expect in this region. Among all these cases, only one case was positive for chest tuberculosis and was diagnosed only after ocular symptoms. The present scenario demands more attention towards early diagnosis and management of ocular tuberculosis and reduce the burden of latent tuberculosis as well as tuberculosis-associated blindness in our society. In my eyes, always consider TB in chronic recurrent uveitis cases and suspect tuberculosis in cases of frequent recurrence of inflammation of any structure of eye and adnexa in endemic regions. And multidisciplinary approach is very essential. Thank you.
Thank you, Dr. Reena. Now I call upon Dr. Rajesh Joshi for sharing his experience on traumatic cataract management.
Good morning, everyone. At the outset, I thank JHOS for this opportunity. I will be talking to you about the traumatic cataract management. In fact, today morning, Dr. Love has shown wonderful cases, and yesterday also, Dr. Rishi had shown some cases of traumatic cataract management. Now, this session being just cases only, so I will skip all these slides and straight away go for the surgical planning. In pediatric patient, risk of development of amblyopia is always there, so this patient should be operated as early as possible. But at the same time, fitness could be a problem in this patient, so that is the important point you should keep in mind while managing these cases. In older patients, diabetes and hypertension associated with peri and post-operative complications. And you should look for the previous surgeries as well, because management of traumatic cataract itself is not just the single thing. There could be other things as well, like patient has undergone corneal suturing or sclerocorneal suturing or had undergone vitreoretinal surgery as well. So this point should also be considered while planning the management of these cases. So it could be a primary procedure performed immediately following the injury, or could be the secondary procedure, like after a few days or months of initial management of the trauma, the patient has developed traumatic cataract, and then we are managing these cases. There are certain advantages as well as disadvantages of these procedures. The type of surgical procedure could be phaco emulsification with intact posterior capsule and good zonal support, or intracapsular extraction, or pars plana lensectomy and vitrectomy, depending upon the situation which the patient presents to you. These are the typical steps for the management of this type of cataract. I will straight away go for certain cases. This was the patient who sustained trauma a few years back, had prolapse of the ciliary body, you can see here, and patient has had a wide cataract. So trying to manage this patient with the help of phacoemulsification, side port incision was taken away from the prolapsed ciliary body part. A side port was created. Being a wide cataract, I injected a Trifam blue under air so as to stain the entry capsule. So the entry capsule was stained with the help of Trifam blue, and the 2.8 millimeter incision was taken. The capsular axis was initiated with the help of the 26 gauge bent needle, and the capsular axis was completed with the help of Utrata forceps. Now, managing these cases with phacoemulsification, you should keep in mind that there could be a posterior capsular rupture or rent or dehiscence in this patient. So, always do slow motion phacoemulsification with all reduced parameters of phacoemulsification. You may have to perform phacoemulsification little bit anteriorly, that is in the pupillary plane, and make sure that you form the chamber properly before you withdraw the probe, and after the cortical aspiration, implant the intraocular lens, making sure that there is no vitreous in the anterior chamber. If you feel that there is a vitreous in the anterior chamber, always stain with the help of triamcinolone. This was the patient who underwent corneal perforation repair 2 to 3 months back, and then he developed cataract. So we are managing this case with the help of small incision cataract surgery, because in government setup sometimes you may have to resort to these cases depending upon the availability of the intraocular lenses. So the capsule was stained with the help of Trifam blue. The capsular axis was performed with the help of the needle. The capsular axis is the most important step in such cases, because if sometimes there is a rent of the posterior capsule, then you can place the intraocular lens over the anterocapsular rim. So the nucleus was prolapsed into the anterior chamber, and the cortical wash was given with the help of Simcoe's cannula. You can always use bimanual cannula depending upon your preference. And the 6 millimeter intraocular lens was placed into the bag. The anterior chamber was formed well, and the IOL was dialed into the posterior chamber. Now this one is very important when we have large posterior capsular rent, absorbed cataract, or membranectomy with IOL. My time is over. Or in patients having secondary cataract. Now this was the patient who had a membranous cataract. The cataract was removed and the patient had large posterior capsular rent. So we did a posterior, we placed the 3-piece intraocular lens, and it was, the haptics were tucked between the anterior capsule and the posterior capsule, and the buttonholing of the optic of the IOL was done. This patient had, this is another case having traumatic cataract with fibrotic anterior capsule. So you can see the capsular fibrosis along with the formation of the posterior synechia between the lens and the iris. We tried to break the posterior synechia, and again the capsular axis was done with the help of Utrata forceps. There is always a difficulty in performing capsular axis in these cases. This is the aspiration of the cortex because the nucleus is ill-formed, so you can either do with the help of the aspiration mode of the Phaco or with the help of the irrigation and aspiration probe. So the loose cortex was aspirated with the help of bimanual irrigation aspiration cannula, and the the plaque was there. So after the placement of intraocular lens into the bag, The capsular plaque was held with the help of the forceps and it was cut with the help of Vanna scissor. You can use vitrector to cut the fibrotic anterior capsule. So the air bubble was placed, and it's always a good idea to place one suture to avoid prolapse of the anterior chamber post-operatively. So these are the conclusions. You should do slit lamp examination properly, examine for the foreign body into the anterior chamber or into the lens itself. The IOL implantation in traumatic cataract enables most of the patients to achieve satisfactory and useful vision, but this depends upon the status of the posterior segment. Always have triamcinolone on the table. If you feel that there is a little doubt about the posterior capsular rent or prolapse of the vitreous. Thank you all. This is this is not the last but not the least as well. So please support me for the member ARC West Zone. Thank you so much.
Thank you, sir. So after listening to so many experiences, we'll just give a 2 seconds break to our
Yes, yes.
for our brain to take some rest. Just a 2 seconds break. Start करें? Now we move on to our next speaker, Dr. Abhishek Anand, for his topic on volcanoes on fire, atypical TRDs and aggressive ROPs in anti-VGF era.
नहीं अभिषेक आनंद वहीं से कर दो ना, वहीं से कर दो, पर स्लाइड यहाँ से हो जाएगा क्या? हाँ 2 मिनट No, they have not copied the thing into this also. So my fault, I was late. I am apologies, ma'am. I am additional professor at RIO, Regional Institute of IGMS Patna. Looking after the retina service. I am the head of the retina service. Yeah. नहीं ऑडियो नहीं चाहिए मैं ही बोलूँगा ऑडियो नहीं चाहिए
We have taken enough rest. Now we move on to our next topic.
Hello everyone, I am Dr. Abhishek Anand. I am the additional professor at RIO IGMS Patna. And today I will be speaking on volcanoes and fire. So the basic theme of this is retinopathy of prematurity. And this thing is very close to my heart. I had submitted this presentation basically to be included in the ROP session. But I would like to thank the team that still they managed to find a place for it. So it's predominantly a surgical topic, but I would like to make it simple because the general audience is of varied class and they are doing varied subspecialty. So basically we all are in an ROP era because a lot of SNCUs have come up and a lot of babies are surviving, and we have a lot of babies who are surviving and they are being given indiscriminately lot of injections. And what is this anti-VEGF is giving is that we are seeing at our place a typical presentation of traction retinal detachments which were not there. So the basic theme of this talk is that even if you have injected and you feel that the baby is doing good, you have to be very closely monitoring those babies because they can present with TRDs, traction retinal detachments, later in their life. So the aim of this talk is to enumerate the different morphology of traction retinal detachments post anti-VEGF injections, which we are not seeing around 5 years, 7 years back now we are seeing it, and to bring out a few of the surgical challenges associated with these atypical TRDs. So although, so we all know that ARP develops in about 3 to 10% of all ROP patients, and about 20 to 25% of these patients will develop traction retinal detachment. So this paper is totally based on this, in which they reported progressive retinal detachment in infants with retinopathy of prematurity treated with intravitreal bevacizumab or ranibizumab. So of these papers, they had around, so of the total number of eyes, there were 83% who had been injected with bevacizumab and 17% of which were injected with ranibizumab. And this was a retrospective data, so it was not a prospective data. They only the eyes which developed tractional retinal detachment they are reported, and they decided they reported 3 types of configuration. One was the conventional TRDs or volcano-shaped detachments. One was the circumferential TRDs, which we can see, and another is the posterior traction fibrosis. So basically, most of these were going in a crunch on the posterior pole. Now what is happening with that when you get this, apart from that we are also getting 4 more configurations I would like to enumerate, that apart from these 3 configurations you are also going ROP with central TRD with a persistent fetal vasculature component, and then there is a posterior zipper-like closure, and then we have predominantly exudative RDs which are bleb-like configurations, and then some are which don't fit into anything. So what is PFB plus ROP component is that you have persistent fetal vasculature along coming up with a ROP component. So let's see in this. So you can see this stalk of persistent fetal vasculature and it is going right to the disc. So what is happening is that there is a posterior tent-like detachment which is happening. Now what is happening in that in these cases, if you don't do a bimanual dissection, then you will not end up with a normal anatomy. So what is emphasized is that if you get a tent-like closure, tent-like detachment, you do have to go for a Sandier-based dissection and try to remove this. What is the caveat? Caveat is that in case you miss or create any break, then this eye is gone. So you have to be very, very careful when you are trying to look for any plane of dissection that you can achieve. If you are not, then better to leave these eyes. Then another is that ROP with, another example of an ROP with persistent fetal vasculature. I will leave this. Another example is a zipper-like closure. Zipper-like closure is that along the superior and the inferior arcade of the temporal, they just come and abut each other. So this forms a zip-like closure. If you don't open that zip, this can be done in a very easy way, in which we can see in this case, that it opened very easily. There was a zip which was closing it, and once you take it out, the whole of the foveal anatomy is revealed, and then the body takes care of it, and most of this opens up. Another advanced form is this, in which you don't know what is happening. This is just a zip which has closed and abutted both the superior and the inferior arcade. The problem is that you are going to dissect at the posterior most region, where the illumination is the minimum, and also the amount of flexibility of hands gets very limited. So if you leave it, this eye is most probably left to not get that anatomical closure, but also the dissection and identifying those tissues is very difficult. So these are our typical presentation which we are seeing in this anti-VEGF era, which we were not seeing previously. So in this case, I was lucky enough that I could establish a plane of dissection and was able to take out that central zip which was closing it. And then another is this exudative, predominantly exudative, in which they have the component of exudation coming up along with a traction retinal detachment, where the role of anti-VEGF comes. This is a case was predominantly exudative. The patient was injected and then he developed a more cicatricial component. So another, and some things are beyond, I was not able to explain why they are happening. So you can see there is a posterior pole on which there is a traction retinal detachment. There is an area of retina which is attached, and then there is a periphery which is also detached. So atypical configurations are also coming up. To conclude, in atypical TRD's configuration can be an unusual presentation post anti-VEGF era. Atypical TRDs can throw unique surgical challenges. Early surgery should be advocated, and these TRDs progress very rapidly. So if you see any case which can, you can see some amount of cicatrization which is happening, do not inject. That is the take-home message. Otherwise, it can deteriorate very fast and you can lose both the eyes. And we should also think of using ultra-low dose anti-VEGF injections in high-risk cases. So thank you for your patient listening.
Thank you, Dr.
Thank you.
Abhishek. Our next topic is amblyopia management in adults using orthoptech. May I invite Dr. Arvind Kumar Maurya for this.
Audio video दोनों चाहिए. Yeah. A very warm good morning, and so this is a world's first such case series on the post-Phaco refractive amblyopia treatment using a new modality, that is the orthoptech magnocellular stimulator. And I have no financial interest, so vision is far more beyond the Snellens or the Logmar, because there are other aspects of the vision, that is the brain ability to process motion, as well as the hyperacuity, contour integration, as well as the shape perception. All these are the important aspect of vision.
And in India, up to 4% amblyopia incidence, and earlier the onset, the greater is the deficit. And the adult refractive amblyopia are regarded as associated with the highest degree of plasticity as well as rigidity. Therapies are the conventional patching, but recurrence is seen in 25 to 50% of the cases. Contact lenses have their own complications and poor compliance. So the dichoptic therapies, the Binox QRC, they are in vogue, but they are expensive. So what is the hypothesis behind this orthoptic magnocellular stimulator? So these are the top-down impulses that originate in the prefrontal cortex and alter the attention mechanism, which in turn affects the striate cortex. And the peripheral stimulus makes the eye to move to ensure the foveal fixation. This is known as the overt attention. And when the patient is fixating on the central light and still can see the peripheral light, it is known as the covert attention. And these covert as well as the overt attention stimulate the lateral occipital cortex via the top-down impulses, and these motor and sensory aspects of vision are used for the development of the orthoptic magnocellular stimulator. So this is how it happened. There is sudden appearance of the light, stimulation of the saccadic movement, and is associated with the stimulation of the fovea in the V1 area. And there is suppression of the retinal area between the fovea and the peripherally stimulated retinal point, and repeated stimulation of the magnocellular cells leads to stimulation of the fovea, and prosaccade, they are associated with maximal stimulation in the V1 area. So to evaluate the effect of the orthoptic therapy, and we don't need any fancy thing, just the palliropsin, the rendered stereo acuity chart as well as the logmar. So this is how it is done. So the trick is neuroexcitatory, they are released within a second, this gap of 140 to 145 milliseconds. So there are the central green light as well as the peripheral red light, the LED flashes within a gap of 140 to 145 millisecond, and it is a 20-minute therapy from the amblyopic eye, and then 5 minutes from the normal eye, and then 5 minutes with both the eyes open. So the whole therapy, it lasts for half an hour only, not more than this. So no gender, no significant p-value difference. But when we compared the post-Phaco logmar, the best corrected visual acuity, and after giving the 3 months of this therapy, there was a significant p-value difference, and on an average 0.5 logmar, it improved to 0.0 partial if we take the average. And the contrast sensitivity increased from the average 0.35 to 1.25. Stereo again improved from more than 800 second of arc to 70 second of arc, almost within normal limit. And 7 anisometropic, hypermetropic, which are treated as the most plastic. Plus they are all adult amblyopia, and 2 anisomyopic amblyopia, and 2 patients of anisometropic amblyopia noted decrease of 2 lines after 6 months. Then we gave them for 2 weeks therapy was given, and after that there is no rebound. And the binocular single vision, it was achieved in all the patients. So let's take one case of the 65-year-old, stereo of more than 800 second of arc, and contrast 0.35. So I think Rishi can understand this thing, Telugu. Audio nahi hai kya isme? So the patient, within 3 weeks, the patient has the 6x6 part, best corrected. वॉल्यूम दीजिए ना. Patient was very religiously doing this therapy. Then in case of kids, we need to be cautious that one of the staff must sit along with them, because they don't pay attention, and we are seeing that the patient is not improving because they have this attention deficit problem. And contrast, it improved from 0.35 to 1.35.
దానికన్నా చూడండి కళ్ళు మూసి తెరిచి.
And stereo from more than 800 second of arc to 70 second of arc.
చూపించండి ఇప్పుడు. అదంతా ఏమవుతుంది, జస్ట్ ఏది కనిపిస్తుందో అది చెప్పండి.
And there is role of functional blood oxygen level dependent MRI also. In one of the patient in the occipital, frontal and parietal lobe, there was increased oxygenation when we did the functional, this blood oxygen level dependent MRI. So other indications, 6th nerve palsy, partial third nerve palsy, Alzheimer, hyperactive children, attention deficit disorders, and it has this earliest recovery and patient needs to carry only a laser torch. Fastest recovery time because we are doing an ICMR head-to-head clinical trial with all the other therapies available for the amblyopia in India. And thank you so very much for your patience listening. Now I request for your support, your blessing and guidance for the post of ARS ARC South. Thank you so very much.
Thank you, Dr. Bharia.
Any question I would be happy to take. Thank you. Yeah, please, Dr. Malay. Yeah, so it's a 3-month therapy. In the first 2 weeks, 5 days per week, followed by alternate days, and later on once a week. So every day we are doing the same thing.
So we have to assess up to 3 months. If there is no response, then only we stop.
But all the patients are, there is not a single case which didn't improve.
Okay.
Yeah, till now.
Okay.
Yeah.
Okay, thank you. Good.
And this gentleman improved in 3 weeks only. And I have no financial interest. It is an innovation by our ex-president ARS, Dr. Santhan S. Gopal, and its cost is 1.25 lakh plus GST. Thank you.
Thank you, Dr. Maurya, for sharing your experience. I now call upon Dr. Divya Prabha for her talk on optic disc sunburst. Dr. Divya Prabha. So without wasting time again, I call Dr. Sujit Das for his talk on a different approach to a case of AVM.
Good morning to all respected one. I have personally chosen this case because I myself want to learn from all the legends present over here. This 37 years female presented with gradually progressive mechanical ptosis for last 6 to 7 years with a past history of trauma 10 years back. She was depressed, she makes herself socially isolated, and she put a big question in front of me. Can you do something for me? This was her question, and I had a challenge whether I can bring back little bit smile on her face. So on manual eye opening,
May I request the backbenchers, Dr. Sunil, Dr. Bharti, Dr. Satyajit Sinha, to please talk a little slowly. We are getting disturbed. May I request everybody in the hall to keep quiet for some time? Thank you so much. Thank you so much.
Thank you, sir. So my challenge with myself was, can I bring back little bit smile on her face? So on manual eye opening, her vision was 6/6. I opened the affected eye with shots with 17 millimeter Hg, and the other eye it was 12 on applanation tonometry. Rest all the examination was normal. So on inspection there was visible engorged veins on the temporal aspect as well as on the lids. Inner aspect there was little bit lobulated surface. Clinical diagnosis of traumatic arteriovenous malformation was made. MRI confirmed the case. But on a MRI angio, there was a double vessel supplying the AVM. One was from the ophthalmic artery feeder vessels, another from the external carotid artery feeder vessels. So we consulted with interventional radiologist. They said they can only go for embolization of the external carotid artery, because if they go for the ophthalmic artery, there is a chance of blindness. Now it becomes a dilemma. Again they have said if they go for a single vessels embolization, after that treatment how much improvement will be there, they don't know. So patient was not satisfied with the counseling, but I had a different plan in my mind, and different plan was going on in my mind. So I keep on repeatedly counseling the patients and the patient party, and it took 6 months to convince her for this procedure. Accordingly, decision was taken, embolization of the external carotid artery branches. In the OT, preparation was started, femoral root was approached. These are their procedures. The guide wire is going through the femoral root, through the heart, chest, through the neck, ultimately at the bifurcation of the aorta. The dye was injected, and the contrast identification of the vessels. Glue embolization with cast of the external carotid artery was done. The event was, the operation, whatever you can say, it is not uneventful. After 1 month, this is the picture, patient was not satisfied, consulted with the interventional radiologist, they already said, we have explained to you this may be happen. So patient was not satisfied, but I had belief in my plan. So after 2 months, I achieved 70%. My aim was to reduce the blood volume of the eyelids. This was my first aim. So she was little bit happy, still depressed, make herself socially isolated. There was reduced vascular engorgement on subsequent visits. After 4 months, I have achieved 80% on my goal. After 6 months, probably I have achieved my 100% goal. Now she can attend social gathering, she is happy. She came out from a stage of depression. Thanks to this glass. This is called crash glass. It has a supporting arm, so it lifted up the remaining leads. So my aim was, when I took it back, so first was to reduce the volume, second lift up the leads with this help. The surprising features, it took 6 months to convince, and after 6 months I have got my 100% achievement. Thank you very much, sir.
Thank you, Dr. Sujit. May I invite Dr. Archana Kumari for a talk on torsion trouble.
A very warm good morning to all of you. Today I am going to talk on tertian trouble. So disclosure is that a written patient consent was taken up for this case. So a brief introduction. Tertian syndrome was first reported in 1881, but the name tertian syndrome came forth in 1990 after Alfred Tertian diagnosed it in a case of brain injury. Intraocular, what is tertian syndrome? It is intraocular hemorrhage that can be at the level of vitreous or preretinal, retinal or subretinal. And it is associated with intracerebral hemorrhage, that is mostly subarachnoid hemorrhage, but can be subdural or following any head injury. So the important point is that 90% of the patients who have tertian syndrome have mortality, and only 10% of the patients with intracerebral hemorrhage who have vitreous hemorrhage per se will survive. So we are dealing with that 10% of the patients who have survived the ordeal. So the management basically is always first neurological management, pehle zindagi bachegi, uske baad aankh bachegi, then pars plana vitrectomy. So the challenges are patients usually present late because they are not in the, mostly it is about like 6 months for unilateral case and average 3 to 4 months for bilateral case, because these patients are not in condition to many times report. A neurofitness is needed, and many times we get a high risk consent, and if we get a high risk, we are allowed to operate such cases, then the risk benefit ratio has to be explained to the patient. So there have been studies published in Eye in 2024 which said that if a case of tertian is taken up for surgery 3 months after initial presentation, the intraoperative retinal tear chances will be higher. So the prognostic markers stand out to be like the time span from intracranial hemorrhage should be less than 3 months, a good prognostic marker. Another good prognostic marker is the age less than 45 years, but yeah, more than 5 years, because in less than 5 years there's chances of amblyopia and absence of afferent pupillary defect. Like any condition where we want to operate, go for vitrectomy, we like eyes with, no RAPD. So that was the point why I'm discussing this case. This is a 22-year-old male who presented with diminution of vision in left eye for 5 months. He had history of cerebral artery aneurysm about 5 months back, and vision in his left eye was hand movement, right eye luckily 6/6, but he had RAPD. So because of RAPD, this patient was refused surgery at many centers in our adjacent states also, and even the parents were like, risk leke fayda hai ki nahi. So this is a big call that as a surgeon we have to make. An eye with RAPD having tertian syndrome, and this is the ordeal. He sent me a photograph yesterday कि मैम आप जब present कर रहे हो तो ये photograph जरूर लगाना. This was the ordeal he went through 5 months back. So a family जिसके 10% mortality, 90% mortality वाले condition से he has recovered and he is here. So I have to take a call if I have to operate that eye. So there are articles which say that irrespective of the timing of vitrectomy and pre-operative visual acuity, these patients should be taken up for surgery and do have very good outcomes at times. So we took up the patient for pars plana vitrectomy, and 25 gauge trocar placed and fusion was placed, core vitrectomy was done. Like any case of very dense vitreous hemorrhage, a very utter care was taken while operating, and then we see a very beautiful PVD is induced. After PVD, obviously a easy vitrectomy could be done 360-degree, but I think you can note that there is still a big clump of hemorrhage in the posterior pole, very undisturbed, and this is the pre-retinal hemorrhage. So when we flush it in the subsequently, after doing we did a good peripheral vitrectomy also. When this subhyaloid hemorrhage is flushed off, the macula is clear. So very meticulously this was done because this is a chronic old hemorrhage sitting on retina. Then fax was done, and after fax we could see that there is a disc and macula was very clear, but there is a pocket. We can make out see there is a pocket here of hemorrhage along the superior retinal arcade. So I had to nudge it, I had to try to flush it, it was not getting flushed. So while in the process ILM forceps was used, I tried to remove it, and there was a break, probably iatrogenic then, and so we lasered the break. Oil was put in the eye for the safety, and the case was closed. So after 1 month, silicone oil removal was done because there was no proper RD, so 1 month time was taken up. And here is the big bang. The BCVA for the patient 1 week post-op was 6.9. Thank you. So we were like, I was as happy as like with today your clap suggest, and then I thought that I should bring up this case. So treating Terson vitreous hemorrhage can be rewarding at any time span, even if the eye has poor prognostic marker as poor as RAPT. Thank you.
Thank you, Dr. Archana. Now we move on to our last speaker of this section, Dr. Deepika Kedia, for a talk on deciding for glasses or squint surgery in children.
Good morning to all the present. Now I'll be speaking upon deciding for glasses or squint surgery in children. So we had a first case of 4-year-old child who had no history of glasses, no history of patching. He presented to us with the esotropia. Distance was 40 PDED, near was 30 PDED. The cycloretino was done. It came at around +7 diopter sphere with -1 cell with +5.5 with -1.5 cell. So we have given full correction in this patient. This is a case of fully accommodative esotropia. Our case 2 is 8-year-old child female with no history of glasses. She presented with 50 prism diopter esotropia, and the retinoscopy was +6 for right eye, 6.5 in left eye. So we went ahead with the glasses. Full correction was given. Under the atropine, the retinoscopy was done. And in the subsequent follow-up, we also started with the patching because the fixation was not maintained in the left eye. After 3 months, the patching results were poor. The patient has a poor compliance with the patching. So we went ahead with the vision stimulation therapy, software-based vision stimulation therapy was given. After 1 year of follow-up, the squint improved and the patient was ortho with the best corrected vision of right eye 6.9 and left eye 6.18. We have another, this is the pre-op and the post-op picture of the child after the 1 year of vision therapy and the glasses. We have another child, 5-year-old male with the 20 prism diopter esotropia. Retinoscopy was done under the atropine. It came at around +5 diopter sphere and +1 cylinder. So for this child also, we have given the full correction. And in the subsequent visit, the fixation was poorly maintained. So in this child also, we went ahead with the vision stimulation therapy. And in the 1 year follow-up, both the squint and the best corrected vision was 6.9 for both child. So so far we have seen the cases of accommodative esotropia, which has some have improved with the glasses only, while some needed the vision therapy. Now we will see in the next cases the role of surgery. So this is a case of left convergent squint with the 35 to 40 esotropia. The BCVA was 6.6 in the both eye, but the squint was still persistent even with the glasses. So this is a case of partially accommodative esotropia. So we went ahead with the surgery in the child, and the surgical result came out to be good in the follow-up. This is another female with the left esotropia. Modified Krimsky was 20 esotropia. Right eye best corrected vision was 6.6, and in the left eye it was 2/60. fixation was poorly maintained in the left eye. So in this child, even with the glasses, she was using glasses of +6 since long time, but still the squint component was there. So we went ahead with the surgery. Post-surgery, the patient was ortho. So this is a case of partially accommodative esotropia. We have another child, 5-year-old child, with the vision of 616 right eye and the 69 in left eye. This retinoscopy show +5 in the right eye and 1.5 in the left eye. So we undercorrected by 1.5 diopter and given the full correction. Because the vision was impaired in the right eye only, in the first visit we have not prescribed for the patching. In subsequent visit, if the patient is not improving with the glasses, then only we go ahead with the patching. We have another child with the 3-year-old female with no history of glasses, no history of patching. Esotropia was 15 diopter for distance and 30 for the near. So this is a case of high AC by A ratio. So here we have given the +3 diopter for the distance, and we have added +3 diopter for the near. And this child we have prescribed for the bifocal glasses. And for the further follow-up, we have used flippers to see for the squint, and gradually we have decreased the near add based on the flipper studies. So for the child, vision is important, the history, refraction, spectacle prescription, and in the subsequent follow-up, we decide whether we need surgery for those patients or not. Thank you.
Thank you, Dr. Deepika. With
Any
this,
questions for the, from the audience?
Thank you again, Dr. Deepika. With this, we conclude this session, and I sincerely thank all the speakers for sharing their experience. So we have witnessed a wide spectrum of valuable knowledge. I also thank our respected chairpersons and the audience for participating in this. Thank you again.
So, we are honored to felicitate Dr. Subhas Dadia by President JHOS, Dr. Jakhanwal, Chairperson Reception Committee, Dr. BP Kashyap, JHOS ARC Chairman officially now, Dr. Sunil Kumar, and JHOS ex-President, Dr. Lalijan, Lifetime Achievement Awardee, Dr. Rajiv Kumar, and Dr. JHOS Treasurer, Dr. Malay Verma. Please come, everybody. Sir, आपको बुलाएंगे इसका. आपका भी. Dr. Vibhuti Bhushan, please come. दीजिए सर फ्लावर ट्रॉफी इधर दीजिए और शॉल दे दीजिए उड़ाइए and we will introduce him also. He has come, has taken time out from his busy schedule. दे दीजिए सर दे दीजिए इसको ऐसे कर लीजिए. Yes. You want to say something?
I am Dr. Professor Subhash Dadia, working at Guru Nanak Eye Center, Maulana Azad Medical College. I have been President and Secretary of Delhi Ophthalmological Society, Secretary Student Union, Rohtak Medical College, President RDA AIMS, Secretary and President Star Wismas and Pediatric Ophthalmological Society, President and Secretary Faculty Association, Maulana Azad Medical College and Associated Hospitals, and I have always raised the issues which are pertinent to common members, and I am contesting for the post of Joint Treasurer in AIOS, requesting for your vote and support.
We will support you, sir. Thank you. And he runs Prayogshala Connect also. Yes, yes. So that is our Prayogshala Connect is also very hit today. So now I invite our ex-president, Dr. B.N. Gupta sir, Dr. Vinay Gupta, Dr. Ajay Gupta. Dr. Bhola Prasad Kashyap, he has come all the way from USA and he insisted on coming. Chairpersons. डॉक्टर भोला जी को एस्कॉर्ट कर दीजिए. Because my entire family comes from USA, but nobody wants to attend the conference. My brother-in-law went one day before, he did not, but he is staying. They all were done their MS in eye. Some became eye specialists in USA, some became physician. Madam, Dr. Sujit Das, Dr. Vinay Gupta, Dr. Ram Kumar, Dr. Santosh Kumar Singh, Dr. Dev Kumar Mehto, and Dr. Kumar Vijay. जल्दी करिए. अच्छा निंजा मैडम दीजिए, बुलाइए अनिता अनुराधा का बेटा. डॉक्टर सुजीत कुमार, डॉक्टर विनय गुप्ता. ये चेयरपर्सन क्या है सर? हाँ चेयरपर्सन. ठीक है. लाओ एक तो फूल लाओ विनय गुप्ता सर के लिए. जल्दी लाओ. कहाँ देखिए सर वो लगता है गलत सर. लीजिए अपने दोस्त को दीजिए. हम जानबूझ के रखे थे. लीजिए पकड़िए ना इसको. हाँ प्लीज कीप द रेडी द अनिंदा अनुराधा's मोमेंटो. नहीं अभी करवा दीजिए. सुजीत दास जाइए. नहीं वहां जाइए. हो गया डॉक्टर विनय, आप इधर आ जाइए. हाँ लीजिए. डॉक्टर राम कुमार, डॉक्टर संतोष कुमार सिंह, डॉक्टर देव महतो, आर दे हियर? आशा मैडम का फूल दो. सर फूल दे देते हैं. अरे मत चाहिए भैया, आप काहे इतना अब बका रहे हैं भाई. लीजिए दीजिए आशा मैडम को. आइए मैडम. हाँ सही बोले. पकड़ी बीच में जाइए मैडम बीच में जाइए. नहीं लोगे दे दिए. हाँ आनंद सुश्रुत, डॉक्टर आनंद सुश्रुत, डॉक्टर अनिंदा अनुराधा, डॉक्टर आनंद सुश्रुत. आई विल टेल. डॉक्टर आनंद सुश्रुत. अरे आइए, अभी तो पहला दिन है. एंड I will tell you that Dr. Anindya Anuradha contributed extensively for JHOS activity, especially online activities of Jharkhand Ophthalmological Society. She has contributed. Yesterday she was absent. She came late. Day before yesterday she was absent, so we could not give her. So today we are honoring her with the JHOS Excellence Award. मैडम आपका हो गया? आओ खड़े। चलो इसको बीपी कश्यप से दिलवा दो। आइए सर, आपको अच्छा ठीक है नहीं एक मिनट रुको ना, जखनपाल सर प्रेसिडेंट है ना? हाँ आइए आइए इधर आइए। अच्छा ओ आपका नहीं हुआ है अभी? अच्छा कोई बात नहीं, अंदर हट जाओ। लाइट है ये किसका है? अनिंदा को कर देते हैं। आ जाओ बेटा एक बार आ जाओ, तुम्हारा आइए चेयरमैन। ये हमेशा
टॉप खत्म करके जल्दी
नहीं सर डॉक्टर कश्यप को देखते हैं, क्योंकि ये हमेशा अपना सब कुछ उनसे साइन कराती है। हाँ so Aninda is getting extra flower. Note, kindly note Sunil. Dr. Shushruth, so you got extra big bunch of flowers. Anand Shushruth. Anand Shushruth. दोनों मेमेंटो मैडम देखिए ना। आनंद सुश्रुत उनको ऑलरेडी दे चुका, अगर देना है तो फिर उसको Anand Shushruth has received already. So this is the dummy. You have already got it yesterday. This she said. He has already got it. चलो फूल भी तुमको दे दिया है, एक्स्ट्रा डबल तुम कर लिया। चलो फूल वापस कर। कल इसका ऑनर हो चुका है, See, we have to start the next Dr. B.N. Gupta session, innovation. So, coordinator. Acha. So, please stay here. The speakers, we felicitate Dr. Archana Kumari and Dr. Deepika Khedia. Dr. Ajay Kumar Gupta. पहले किसको करना है? फूल दो हमारा नया एमसी मेंबर फ्लावर। आज तुम लोगों को फूल मिल रहा है बड़ा, उसको वापस कर देना। चलो डॉक्टर दीपिका खेडिया मैडम। फूल भी दे दो, ताली बजाओ निंदा। चलो दीपिका इधर आओ। चलो आओ अर्चना। नहीं हो गया, वो दे दिया वही वाला। अरे सर है अभी। Very nice. Dr. Reena Kumari. Dr. Poonam Sundar is from day one. Give one chairperson memento to her. Dr. Poonam Sundar, please come. Flower do. Lo. Poonam Sundar. And please stay back, all the dignitaries, because we have to dispense trophy for the winner of the quiz also. Yesterday we could not. I hope Dr. Poonam Sundar. लो. हाँ हाँ पूनम तुम इस पे स्टिकर चेंज कर लेना. लो बेटा. Dr. Shruti Hegde. Dr. Shruti Hegde. Dr. Shruti Hegde is Guru Sangam award winner. She got appreciation in Guru Sangam. Please clap for Dr. Shruti Hegde. And she is our leadership candidate from Jharkhand. She got Guru Sangam award. She is recognized as one of the best teacher out of 10 teachers, out of 10 recognized teachers of India. She is one. बहुत अच्छा किया. Now we invite the most successful coordinator of AIUS Prayogshala, Chief Coordinator, Dr. Nidhi Gatka Kashyap. She organized it most beautifully. Clap karo. मेरे से भी नहीं हो पाता. She did so marvelously. 4 microscope, iris claw, IPCL. Come. And very, very sincere girl. Very sincere. It's not chairperson award, it is for the best conduction, and we expect during his tenure also, you have to conduct it the way you conduct it, you have to conduct in Dhanbad. Promise?
Yes, I will. Yes, sir, yes, sir.
And you were the NABH assessor also. You remember, sir, your duty. Very nice Prayogshala, 3 days she did. And she did not witness her husband's felicitation because some of the PGs requested her to teach corneal suturing. It is amazing. Very dedicated lady. Now, हो गया? राहुल प्रसाद का सुनील आप आइए ले लीजिए. Come. Session coordinator. Flower दो. रजनी दीपा कुजूर. नंदी जराई is there. नंदी जराई को भी दो एक. आओ. Flower. He is the best JHOS ARC chairman. He supports. He is very supportive. Whatever I organize, he supports. He is the best chairman of JHOS ARC. Dr. Nandi Jarai. Dr. Soni Sinha, आपका हो गया? पूछ रहे हैं. Yesterday. Okay. Hey, Dr. Soni Sinha का लाओ. सोनी सुना प्रतीक उन लोग का फेलिसिटेशन कर. हाँ कर दो. They were not there during the time of felicitation by Honorable Health Minister, so I am just winding up everything. ये किसका है? I think Ravi Ranjan is also not felicitated yesterday. हो गया था तुम्हारा? नहीं. Soni Sinha, we invite Dr. Soni Sinha. Is Pratik here? Pratik? Pratik. और रवि रंजन रखो. सर लीजिए. सर अभी खसकिए तो थोड़ा सा. हाँ. अभी नहीं, रुशद का भी करा दो इसके बाद, इसके बाद। राजीव सर, यू वांट टू कम? ओके, प्रतीक आ जाओ। Yesterday he missed. Ravi Ranjan. दो। अच्छा, ये तो हम, ये दीजिए सर, ये लो बेटा। सर जल्दी आइए इतना। हम लोगों का चलिए प्रेसिडेंट के बगल। हाँ पीजिए। हाँ डॉक्टर एंडी मिश्रा, इज ही अवेलेबल हियर? ओ डॉक्टर सचिन, डॉक्टर सचिन फ्रॉम NMCH, डॉक्टर सचिन। डॉक्टर सचिन आ जाओ इधर, इधर 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 से। डॉक्टर सचिन का दीजिए। डॉक्टर सचिन का क्या है? वॉज ही स्पीकर? सचिन का स्पीकर। हाँ सचिन इधर से निकलना। बड़ा वाला लो, बड़ा वाला। थैंक यू। इधर से सचिन, इधर से। डॉक्टर टीपी बर्नवाल, डॉक्टर टीपी बर्नवाल विथ वाइफ, ही वॉज प्रेजेंट ऑल टाइम। सुनो, डॉक्टर टीपी बर्नवाल। अरे नहीं, वैसा नहीं। अरे दे दो।
इन्हें विनर का है। हाँ? विनर का है।
आइए।
दे रहे हम कुछ किया ही।
अरे कोई बात नहीं है, चलो ना, रहा ना इतना बुढ़ापा में।
हाँ बुढ़ापा, अभी बुढ़ा मत बोलिए।
चेंज कर लीजिएगा स्टिकर, हो जाएगा चेंज। I think it is all done. डॉक्टर पंकज कुमार, हो गया है ना? हाँ, yes. Rushad is a very session, the session after session. It's a very, very honored session. Quiz winners. Quiz winners. सुनील बॉस आइए अपना ट्रॉफी लेके। ट्रॉफी, ट्रॉफी शॉल लेके आइए।
सर कल हमको कल हम लोग को जबरदस्ती करवाया
पूछी पकड़ के हेल्थ मिनिस्टर पूछी पकड़ के।
रवि
रवि भाग गया।
डॉक्टर लव पहुंच गए का डॉक्टर आनंद शुक्ल ले लेंगे, वो ले आएंगे, वो नहीं आने वाले।
ले अच्छा वो भी लाओ ना, वो ऑस्कर, ऑस्करो लाओ ना।
ऑस्कर है यहाँ पे। अच्छा नहीं देगा, लाओ जल्दी करो बीएन गुप्ता सेशन। ज्ञान भास्कर का ले जाना, कोई बात नहीं, ले भी जाना ज्ञान भास्कर ले जाएंगे, ज्ञान भास्कर का है, ले जाना। सुनिए आपका हो गया सर? सुधीर का भी कर दीजिए। ज्ञान भास्कर, हेलो ज्ञान भास्कर का दे देना। सुनील के साथ पार्टनर है, वो भी बस नहीं हो गया। चलो ऐसे पकड़ो, हाँ चलो, हाँ। अब नेक्स्ट सेशन रुशद का, प्लीज Dr. Love Coach Gave has gone. Dr. Anush should please come. And please stay back. Nobody will leave. There is a very innovative session, and Dr. Rusha Shroff is a winner of not only our JHOS innovator session, he's one of the winner of hackathon also na, in LVPI. And in his busy schedule, he took his time off. Chalo jaldi karo. अरे ऐसे करो ना, ये शॉल लगाना था, नहीं सब जगह ठीक है, हो गया, चलो चलो प्लीज स्टार्ट द सेशन, प्लीज। कोऑर्डिनेटर ऑफ द बीएन गुप्ता सेशन आप हैं, कोऑर्डिनेटर प्लीज सर कुछ बुलवाइए, कितना टेढ़ा मेढ़ा कर दिया है सर। So this BN Gupta innovation session is kept in the name of Dr. BN Gupta, the one of the founder member of Jharkhand Ophthalmological Society, and this is for the first time. This is initiated this year, and for the first time we are starting it. And the first winner is Dr. Rusha Shroff, and introduction of Rusha Shroff. Introduction slide of Rusha Shroff. Premlata, Ankur. Where is Ankur? Introduction slide of Dr. Rusha Shroff. देखिए सब होता है ना कि हम भूले रहते हैं, लेकिन वो करता नहीं। ऐसे बहुत बड़ा कॉन्फ्रेंस हो गया, नहीं संभाला।
In the meantime, I welcome Dr. Rushad for this the maiden award of Jharkhand Ophthalmological Society as a innovation award. Dr. Rushad, I have got a strong bonding, although he is a very renowned surgeon from Delhi, and he has been very active, very dynamic in the society. But I have got a special bonding. He is the son-in-law of my younger colleague, Dr. Hariom Arora. So that way also, I have got special bonding with Rushad.
But we will like to say,
welcome Rushad.
Yeah.
You really truly deserve this award, because
we will like to say this award is not by choice. We have not selected. He has won in our midterm conference, and among all the innovators of the country, because he's international hero also. And in LV Prasad, they organize a hackathon session, and we invite all those people and some other people also. And in our midterm conference, we also organize online. And in that online session of Jharkhand Ophthalmological Society, he came out as a winner.
Thank you so much for this honor, and I'm sorry I couldn't be here yesterday. There was a commitment at Shroff Charity. It was the 100 years of the building, so I had to be there yesterday, and I couldn't make it yesterday. But thank you so much for honoring me. It is a very humbling experience to get an award like this, and I'm humbled and truly honored to get it.
You are getting honor after honors in so many societies. I can see this. Do you have your intros?
I will have it on my phone, ma'am.
सर आप पढ़ेंगे? पढ़िए। अच्छा ठीक है। Dr. Anindya, please come. अब तो अभी है ओरेशन के बाद बोल दो. Please introduce Dr. Rushad Shroff.
Thank you. It's an honor to introduce Dr. Rushal Shroff. So Dr. Rushal Shroff is currently working as a consultant and medical director of Shroff Eye Center, New Delhi. He completed his postgraduate training in ophthalmology from the Regional Institute of Ophthalmology, Trivandrum, and his fellowship in cataract, refractive cornea, and optics from Narayana Nethralaya, Bangalore in 2017. He has 23 publications in peer-reviewed international journals. He has won numerous free paper and video awards at national and international conferences, including the Best Video Award in the cataract category at ASCRS and ESCRS. He has also won the Best Paper of Session at the SCRS and APA-CRS. Meetings of his works on ocular surfaces, disease, and lenticle extractions procedures. So we really congratulate you from JHOS getting this maiden award for the first time in Dr. B.N. Gupta's Gold Medal Award for the Best Innovation. Thank you so much. So, please.
I'll just get my laptop. Sure.
And now I request and invite Dr. Rushad to present his deliberation.
So, thank you so much for those very kind words and for this honor. This is actually what we presented and what I've been working on with a couple of my collaborators, Dr. Matthew from down south in Cochin and Dr. Bharat, who's our technology partner from OTOS. It's basically an app which is freely available on the Android system, so anyone who has an Android phone can actually access this app. And it's basically a dry eye screening modality, and I'll show you how it helps in actually management of this as well. So why is dry eye a problem nowadays? Well, because we are having a larger and larger number of patients coming in with symptoms of ocular surface disease, and very often you have these kind of patients where the symptoms are out of proportion to the signs, where the Schirmer's is normal, the TBOT may be normal, but the patient is very, very symptomatic. And the tear metrics don't always explain these disproportionately high symptoms that the patient has. Now, very often, and we know this from ocular surface analysis, that a normal blink rate and a normal tear breakup time generally means that the patient's symptomatology is pretty good. When someone has a breakup time before the blink, actually, that's when digital eye strain symptoms actually come in. Now, there's enough evidence for this from the TFOS DUES2 report, and there's a growing need for objective markers rather than subjective markers. There are also publications talking about blink type correlating with symptoms and how incomplete blinking actually increases the odds of dry eye disease developing. And we've all seen this kind of picture on the slit lamp when we do a fluorescein staining. You can see this kind of punctate erosion, filaments, etc. And just a simple staining can actually tell you this. You don't need fancy diagnostic tools. Now, the knowledge gap in this is that out of the existing research, there are very few studies that objectively measure blink kinematics. And there's no study in India that actually looks at a blink reminder and the impact of that on symptomatology and on treatment actually. So the limited research connecting blink patterns, intervention, taking care of those blink patterns and increased productivity of people is what we wanted to look into. This is the name of the app which is available. It's called ID, which you can find on your Android system. It's a blink reminder, so you have what are called partial, smart blink reminders and fixed blink reminders, which means that you can set the time that the device will actually give you this reminder. If you look at the eye-shaped icon on the top left of the screen, that's how the reminder actually looks, and I'll show it in a subsequent video. It also has the 20-20-20 rule inbuilt, so it will tell the person to take a break. It keeps running even when you're not operating this particular app. So if you're working on your system using whatever application you're using or whatever work you're doing, it will continue to actually run. This is a video showing the same, so it has the ability for you to move the size of the icon, make it bigger or smaller. There's an auditory prompt also, so if you want to switch the video of that off, it will be a sound that will remind you to actually blink properly. And that's how it appears, that kind of blinking thing. Apart from that, like I mentioned, it has the 20-20 rule break built into it. So while, say, an EMR is running or anything is running, it will tell you to take a break. Now, the purpose of this study that we actually looked at was, will this actually make an impact to symptomatology, and how will it impact management in the future? So we looked at this prospective cross-sectional study of about 150 software professionals. We did intervention in 44 patients, and these were people who were using more than 6 hours of professional screen usage. So we measured the blink kinematics, which is our normal metrics, and the blink patterns before the intervention. We did the intervention with the app, and then we looked at all these things later. So we looked at symptomatology in terms of OSDI scoring, the tear film parameters, and the high-order aberrations. So we looked at the OSDI questionnaire for objective measurement of symptoms. We did a slit lamp examination, a fluorescein staining. The IDRA was done at Dr. Matthews' site. At our site, we used the LipiView and the keratograph to actually measure tear film metrics, and we did a Schirmer's test as well. So before we actually deployed this, we ran the app without telling the subjects that they were being subjected to this, because the very thought of an app running can change your blink kinematics at times. So we did that initially, then we had a health education webinar where we told them this app is running, then we did the app, and then we did the post-intervention measurement about 3 months later. Now, these are the results of this particular analysis. You can see that the blink, these are different blink parameters. So how it works is the camera in your phone or on your device actually is continuously monitoring your blink pattern. So the blink rate actually improved, but not statistically significantly. The duration of the blink actually got better as well. The interblink interval, that means the time between the two blinks, became a little bit less. The partial blink percentage significantly became better, so that reduced. And the thermography severity scores, which is basically a function of evaporative dry eye, became a little bit better in this as well. When we looked at the Schirmer's, TBUT, etc., the TBUT showed a significant improvement. And interestingly, the aberrations in terms of spherical aberration, corneal high order aberrations, the tear meniscus height, and the OSDI scoring all showed significant improvement in this subset. We did a subgroup analysis, basically breaking up these patients into normals based on OSDI scoring into normal, mild, moderate, and severe. This is the baseline analysis showing a significant difference in non-contact TBUT and Schirmer's. And after the intervention, all those differences actually became insignificant except in the severe group. I'll come to that in the next slide. What I basically mean by this is, this looks like a pretty busy slide, but I want you to pay attention to the percentages over here. So pre the intervention, the normals were 50%, mild symptomatology in OSDI and moderate symptomatology was about 36 and 9%. So 45% of patients had mild and moderate symptoms. Post the intervention, there was a conversion of that group, the mild and moderate symptomatology group, to normal. So that means their OSDI scores got better in the normal range. So post the intervention, 73% became normal. The mild group reduced from 36 to 18%, and the moderate from 9 to 5%. Showing that it has a role in intervention in these subset of patients where it's mainly mild and moderate symptomatology. In the severe group, there was not much change because the severe group would have other ocular surface pathology which would be causing the dry eye. So the positive cycle of healthy blinking basically means that an improved blinking will lead to better tear spreading and stability, reduction in high order aberrations and clearer vision, along with better tear meniscus parameters and tear metrics, leading to improved comfort and productivity. Now, this is basically to show you the impact of this. Now, Tata Consultancy Services actually did this analysis of their employees, and out of almost 5-6 lakh employees, about 50% was shown to suffer from some amount of dry eye. That's about 300,000 employees. Now, the Osaka study has said that there's an average productivity decline of about 5% in patients suffering from dry eye disease. And just calculating the impact of that, if you look at this 5% of about rupees 50,000 on an average, it comes to an impact of 6,750 crores over a year. So showing that actually just controlling blinks and not doing any pharmacological intervention, we didn't give these patients any drops or any artificial tears, can improve someone's productivity to that extent. So improving blinks can improve comfort, vision and productivity in software professionals. It's better to think of this more as an investment and rather than the cost of this intervention. So thank you for a very patient listening, and that's.
Thank you, Rushad. We are honored to have you in this Jhoscon 23rd conference, and we are also honored to start this session with you. I invite all the office bearers of here, Jharkhand Ophthalmological Society, आइए, and Dr. B.N. Gupta, on which name it has been started. The President, please come. Please bring the ट्रे में लेके आइए. हाँ. So Dr. Bharat Singh is the session coordinator. He has not come. Dr. Smita Anand, Dr. Deepika Khedia, Dr. Sarojini Murmu, Dr. Renu Mair, Dr. Shruti Hegde, Dr. Nandi Jarai, please come. Dr. Poonam Sundar, please come. Dr. Vibhuti Bhushan, Dr. Mala Verma, please come to the dais. Best of the East session, please honor it. Best of the East session. हाँ, no. First keynote address. Rushad, अरे तो हो गया. Maya Hada, it's there. So first we will be starting with the keynote addresses. There are three keynote addresses. Maya Hada, Swati Thomas, she's absent, and Rishi Swarup. And after that, the presentations will be from the East Zone of India, Bihar, Jharkhand, and this West Bengal.
So Dr. Maya Hadda is going to present on complex cases of orbital tumors the aesthetic way. Please, ma'am.
Dr. Seema, MGM Associate Professor, please come to the dais. Dr. Archana, please come and be the discussant. We need vibrant discussants also.
Thank you, ma'am. I'm really grateful to Jharkhand Ophthalmological Society for this opportunity. So I'll be discussing few video-based cases of complex orbital tumors. Whenever we deal with orbital tumors, the ultimate goal is to remove the tumor along with the preservation of the function and to give best possible cosmesis to the patient. So this was a case of a 32-year-old male, and you can see the right eye is having axial proptosis. Also the vision in the right eye was a little bit decreased. When we see the MRI pictures, you can see on the axial section there is a large tumor sitting right behind the eyeball, and the optic nerve is displaced on the medial side. So the tumor was causing stretching of the optic nerve, and that was leading to decrease in the vision. As it was an intracorneal retrobulbar mass, we planned the surgery via lateral orbitotomy approach. So this was done under general anesthesia. So conventionally in the lateral orbitotomy surgeries, we used to make a stellar dried incision, which was long incision and then going in an S-shaped manner. But I have shifted to this lateral canthotomy incision, which gives a very nice, scarless outcome. So after making this canthotomy and separating the skin and orbicularis, I'm making an incision on the periorbita, on the lateral orbital rim. The idea is to separate the periosteum so that the bone is exposed, because to reach the intracorneal tumor, we have to remove a piece of bone from the lateral orbital rim. So after clearing off all the tissues from the bone, now the bone is exposed totally. We'll make a cut, an osteotomy will be done. This is a striker bone saw that I'm using to make the bone cut. So this piece of the bone will be either we can reflect it or we can remove it totally. So here, mallet hammer sometimes we have to use if the bone is very thick. So with the help of this mallet and hammer, then I'm removing this bone piece. This is the temporalis muscle that is attached to the bone piece. It is reflective. Lateral rectus is again, retracted. We don't have to do any kind of sharp dissection in the orbit, so only blunt spatula or use your finger to clear off all the adhesions. This is a cavernous hemangioma. You can see the purplish mass, and after clearing off all the adhesions, we apply this cryoprobe to gently remove it in a rotatory manner. And whenever you feel any kind of restriction, then again proceed with the adhesion release, and then only you go ahead with the removal. So then you have to monitor the pupil throughout the extraction process. And then after achieving the hemostasis, this bone piece is again reposited. The periosteum and the soft tissues are sutured back, and then the incision is closed. So this gives a very nice cosmetic outcome. And after, few weeks, there is hardly any scar which is visible. So this is the pre-op and the post-op photograph. This second case was again axial proptosis. You can see that the eye is little bit, displaced downwards also, because she was having the tumor on the superior medial aspect of the optic nerve. So here, conventionally what we used to do is, lid split approach. And this is again likely to be cavernous hemangioma. You can see the enhancement with the contrast. But my preference is to go transconjunctivally through the superior fornix, because lid split gives you a very bad scar on the eyelid. So after doing this scanthotomy, and I made this fornicial incision to approach this tumor via conjunctival approach. So separating the tenons, as I said, only blunt dissection is permitted. These are the ribbon retractors. You can use malleable retractors also. And if any major vessel, you can cauterize it over there. Again, this was a hemangioma case, but it was a very large hemangioma, and the space was very limited because it's a superomedial orbit. You can't remove bone, and you have a limited space. And whenever you try to pull out the tumor, sometimes the pupil dilates, and then again, you have to be very careful removing these tumors. So applying cryoprobe, and gently rotational movement is done, and then a large tumor with the pedicle, which was then clamped and cauterized, was removed. And then the incision was closed with atovicral continuous suture. A similar case via transconjunctival orbitotomy. This was a very interesting case of abaxial proptosis, and not a solid tumor, but multiple large cysts were there in the orbit. You can see these are the multiple cysts which are going into the ethmoid sinus and also reaching to the orbital apex. And the optic nerve is very much stretched. And on ultrasound, we can see a double wall around the cyst. So that is classically of a hydatid cyst. But we have never seen multiple hydatid cysts in the orbit. So this was a very challenging case, how to approach these large cysts in the medial orbit, which is very challenging. You cannot, you don't have a bone to remove, and there is always a chance of rupture of the cyst. So I proceeded with this anterior orbitotomy approach. You can see that there are vessels intervening. There is this tendon of superior oblique. And this is the cyst, which you can see the wall. The white colored large cyst is there. So we cannot remove the cyst in toto, and any attempt will lead to rupture. And it is said that if hydatid cyst rupture, there can be anaphylaxis also. So we aspirated the cyst contents, monitoring all the vital parameters. And you can see the clear hydatid fluid which is aspirated. And when the cyst was decompressed, so this outer wall is basically a condensation of fibrous tissue which you can cut open, and these are the inner daughter cysts, which are the laminated membranes which you have to remove. So multiple daughter cysts were seen inside this outer wall, and then I removed them one by one with the help of cryo extraction, and very carefully because hydatid fluid, if once spilled in the field, then you have to give a thorough wash, and there is always a chance of dissemination and local recurrence. So these are the three cysts which were removed. There was again a large posterior cyst which was then removed. This was the cyst impacted in the ethmoid, and the last very tiny. So total 5 cysts were removed, and pupil was monitored, and the wound was closed and sutured. And we confirmed it on histopathology, and it came out to be hydatid cyst. So this was the post-op photograph, and he had no recurrence on 3 years. And the last one again, hydatid cyst, but this was a unilocular large intraconal hydatid, and this one I removed with the transconjunctival approach. So you have a variety of locations for the hydatid cyst, and here again I prefer doing an aspiration prior to removal, and because I was sure of my diagnosis, so I inserted the needle in the orbit, and again the cyst was decompressed. And after opening up the fibrous wall, you can see the white, shiny inner, daughter cyst. And this was then prolapsed and removed with the help of a cryoprobe. Slight dilatation of the pupil happened, but then it resumed its, normal circular shape. Came out to be hydatid and no recurrence. So we gave a course of albendazole in post-operative period. To conclude, I'll say that thorough radiological clinical evaluation is important for the management of orbital tumors, and with the minimally invasive orbital surgeries, we can achieve a good functional and aesthetic outcome. I request for your blessings and support for the member scientific committee post. Thank you very much. Yeah.
Thank you, Dr. Maya, for sharing such a beautiful videos. So I request Dr. Malay Burma to give his comments because he is the prominent oculoplasty surgeon of Jharkhand. In the meantime, I'll request Dr. Rishi Swarup to get ready for his talk on cataract surgery in scarred corneas.
Yeah, Dr. Maya, thank you for sharing such nice videos with us, and congratulations for obtaining a bloodless field.
Thank you.
In all your surgeries. My two inputs which I wanted from you, when you're removing that bone fragment and when you're repositing it back, anytime do you require to use glue or a suture to fix it, or it suffices to just place it there?
In this particular case, the muscle was attached to it, the temporalis, so it was in its anatomical position. Otherwise, if you feel that it's not stable, you can use the microplates to fix it. So sometimes I use the microplates and the screw to fix it.
Okay. And the second one, when we in all those hydrated cysts, those also were very nice cases. When you were aspirating after that, did you ever decide to inject a glue into that to stabilize the cyst wall or anything?
No, the idea is at the point, when you apply the cryoprobe, you apply it on the point of aspiration. Okay. Otherwise, there is a minimal chance of leakage because it's already collapsed cyst and the point gets self-sealed on its own. Yeah.
Okay, thank you. Thank you, Rohit.
Thank you.
We'll change gears. I'm going to talk about cataract surgery in scarred corneas, specifically phacoemulsification in a case of scar. When we talk about a scar, traditionally we divide scars into nebula, macula, leucoma, but it's not really the density of the scar that's so important. It's also the location and the size and how much it's affecting your visualization and the visual axis. And so this is the decision tree that I follow. If it is a small eccentric scar that is not really causing much distortion in the cornea and it's not going to hamper your visualization, you just go ahead and do your regular cataract surgery and ignore the scar or opacity altogether. But if it is something that is paracentral or in the visual axis, then you have to do something called a phaco plus, which means in addition to your regular surgery, you have to take additional steps to improve your visualization, to make the surgery safer, and also to improve the patient's visual outcome. But if it's a dense opacity which is really not going to allow the patient to see nor you to see, then that scar needs to go and you need to combine your cataract surgery with a keratoplasty, which is called a triple procedure. So what are the problems when you're dealing with a scar? You have problems in seeing all the steps of surgery, so you can have a problem of complication if you don't see well. There are problems with biometry and calculation of the correct K value for the IOL calculation. And of course, choosing the right lens, toric versus non-toric, there may be a component of irregular astigmatism, and you may want to decide your lens according to that. So in a case like this where you have a peripheral scar, sometimes if it is causing a irregular astigmatism, even though it's not in the visual axis, you may need to do a regularization of the cornea with, say, a topography guided laser, and then once the cornea is having more of a regular astigmatism, after a couple of months or 3 months, you can proceed with your cataract surgery with or without a toric lens and go as usual. But if it is regular, you can proceed straight away. So these are some small tips to improve visualization in opaque corneas. One is use smoothing agents on the surface. Simplest is to put a dispersive OVD on the cornea. So if you have irregularities on the anterior surface of the cornea, they will cause alteration of the refraction at the corneal interface, air film interface, and putting a OVD certainly improves your visualization and also allows for some magnification. Second is using the right light source. So if you have access to a chandelier illumination, you can use that. Otherwise, just a simple light pipe which is freely available, all VR machines have it, but even this is available standalone as a light source which you can connect a fiber optic cable to. And you see, even in a cornea which is so badly scarred and vascularized, the moment you put a light source from the side, everything inside the eye gets illuminated. You can put it either on the surface of the cornea obliquely, or you can even take it through the paracentesis into the AC and use it like a second instrument. So, and what you can do is you can use it for literally every step of cataract surgery, right from the rexus till the PC polishing, and I use it all the time. And this is a standard thing in every OT of mine. We have an endo illuminator because it's very cheap and it can really save the day when you have a problem. Even other complications like PC rent, desmus detachment, etc. can be seen much well. So you see how well the edges of your pieces get highlighted. And once the microscope is switched on and this oblique light is switched off, you'll realize that the scar is actually quite dense. Here you can see everything like a regular case. And the moment we switch to normal illumination, you'll realize that there's a dense central scar, which through a regular microscope would have been difficult to see through. And many of our newer microscopes also have the option of retro illumination, and you have these special attachments that you can put like OmniGlow, etc., which allow for good retro. So especially for rexus, that makes it a lot safer, and that's another thing you can use. If you have problems like opaque epithelium or superficial deposits like this case of spheroidal, sometimes just doing a debridement itself will improve your visualization. Using stains to stain the capsule, devices to enlarge the pupil, all of these will help us see better so that we have less chance of complication. Finally, if your epithelium is creating a problem, don't hesitate to take it off. Scraping the epithelium is also another option that can be done whenever needed. So this is just to show a case of post-graft where the epithelium had Salzmann nodular degenerations and the patient needed a cataract surgery. So we just debrided the epithelium and proceeded with cataract surgery, and you could see a lot better after that. So essentially, do whatever you need to improve your visualization so that the surgery becomes safer and the patient can see better post-operatively, so that after you see well intraoperatively. This is just another video of a patient in which we, just to show that we have used a Gupta ring, which is like a Malugan ring, then endo illuminator to improve. And here we are seeing the retro illumination of the microscope, which makes the irrigation aspiration a lot safer. So it can be useful in various steps of the cataract surgery. And this is a simple tool that you can use within your microscope itself to just start seeing things a lot better. So this is one more patient in which along with the cataract surgery, we have enlarged the pupil in the inferonasal area, like a little bit of an optical iridectomy, so that the patient could have good access around the scar to see, especially for near. So this is another other small measures that you can do to kind of improve the patient's vision. This is just another case example. 26-year-old patient had a chemical injury. Initially, we done a cultivated limbal epithelial transplant in which we take limbal tissue from the fellow eye, grow it in a lab, and then transplant it on the surface for a stem cell deficiency. So as you can see, the cornea is cleared up quite well, but a peripheral scar and a little bit of residual pannus was there in one area, and that was causing quite a bit of astigmatism like so. And this patient, we put a toric lens, and actually the patient got a very good outcome. You can see 6/9 BSCVA was achieved. Finally, when you have a scar which is too bad, then it needs to go out along with the cataract surgery. So either you can combine it with a penetrating or a lamellar procedure. Traditionally for penetrating, we've been doing an open sky cataract surgery after removing the corneal button. But the problem with that is there is always risk of expulsive and positive pressure, vitreous loss, etc. So if you can see, if the scar is not so bad, you can of course do a closed chamber and then do the penetrating keratoplasty, but often that is not possible. So this was a case in which you had a central scar, and we actually managed to complete the cataract surgery by seeing around the scar using various measures, and then we finally opened up the cornea and did a penetrating keratoplasty, and that of course was quite smooth and the patient got a good outcome. But sometimes when the scar is too dense, you can't do that, and traditionally this is what been doing. We kind of remove the corneal button, then do an open sky cataract surgery like is being shown here, and then put the new button and suture it. But sometimes you can have risks, like I mentioned, PC rent, vitreous loss, and expulsive. So what I've been doing for these cases is I do a lamellar keratectomy like is being shown in this particular case. So we remove enough cornea so that the opacity reduces enough to be able to do a safe cataract surgery. And then through that, then you use all your other measures using dispersive OVD, endoilluminator, you can stain the capsule, etc., etc. Whatever you need to do to improve your visualization and to do a safe closed chamber phacoemulsification. So here you can see we are using the endoilluminator probe. And then after you've implanted the lens, you can just kind of excise the corneal button, rest of the cornea, and then suture up your new cornea in place and get a good outcome and a safe cataract surgery where nothing is out of control. So this is a cataract surgery, phaco being combined with a deep lamellar keratoplasty. The entire stroma has been actually excised, and then we've just got the Duas layer and Descemet's membrane there, but this is just to show that you can go ahead and do a regular cataract surgery, maybe just lower the bottle height a little bit, and the Duas layer is strong enough to withstand this IOP, and it really doesn't cause a problem. So even if you remove the entire stroma, you can do this. So to conclude, cataract surgery in opaque corneas poses many challenges with IOL calculation, selection, intraoperative visualization, and propensity to complications. Using small tools like endoilluminator, trypan blue, pupil expanders, etc., make all steps of cataract surgery safer and more predictable in mild to moderate scars. Closed chamber cataract surgery is preferable and possible in almost all cases where cataract surgery has to be combined with the keratoplasty. With this, I'd like to say thank you, and this is my last talk here. Thank you to Jhoscon and the local organizers for wonderful hospitality extended to me. Thank you.
Thank you, Dr. Rissi, for a wonderful presentation on cornea scars and cataract. So I would like to know whether Dr. Salil is present. Dr. Salil Kumar Mandal is the next speaker.
She's saying.
Thank you.
Yes.
Just a small question. Meanwhile,
Yes.
excellent presentation.
Thank
you so much for sharing that. But out here, you know, for the cataract surgeons, I think many of these things that you did will be for your specialization. But one thing that I could see is like debriding the epithelium is something that, you know, in general phaco surgeries, people can do. So do you have any like cutoff, or when you think that the epithelium, this is the right time to debride the epithelium, or this can help? Sometimes we feel it's getting hazy, we don't know it is because of the surgeon is not aware, it is because of the endothelium, or the epithelium is to play a role. Please put some light on it.
So if you've seen the patient on slit lamp before and you realize that the problem is in the epithelium, of course you can plan and do it intraoperatively. Sometimes the epithelium becomes hazy intraoperatively because the endothelium is not taken well to the ringal lactate. If you're using ringal lactate to do surgery, some cases will have this cornea becoming hazy. If you shift to BSS, that goes away. So if you have intraoperatively the cornea becoming hazy, try to change your irrigating solution.
That's a good takeaway.
Yes,
Thank
you
you.
can
Thank
do
you.
that.
Actually, as
And
retina surgeons,
in such cases, you can again debride the epithelium and suddenly your view will improve, but you'll have an epithelial defect to deal with.
yeah. So then, like, do you put BCL on the table?
Yes,
Would you
of
prefer
course,
doing
yeah.
that? Yeah.
You can put BCL post-op for any case, even if you have a small epithelial defect created during cutting the drape or anything.
Okay. Thank you.
Immediately. Yeah, no problem, ma'am. Yeah, you're giving antibiotics as well, no? Yeah, it's fine.
Thank you, Dr. Rissi,
Thank
for
you.
the clarity.
Past history of keratitis is there, then in that case, we have,
I didn't get your question. If there's a history of keratitis,
like previous history of keratitis is there, we are
Yeah.
aware of the fact that that patient is having
you're taking the patient for
keratitis.
cataract surgery. So if
Yeah.
it's a viral case of viral keratitis, you must do the case under antiviral cover. And preferably at least 3 to 6 months of no active episode, and then you go ahead and do it. So if you've had a recent keratitis, give at least a 3 months gap of no active episode before you proceed with cataract
We are
surgery.
doing that, but in spite of that, no,
They are recurring.
we can
So you have to
see
give
that
prophylactic
reactivation
antiviral, ma'am.
happening.
Yeah, 400 milligrams BD and continue it
Yeah,
post-op for at least 3
400
months. Yeah. Okay.
Thank you. So I guess Dr. Salil Mandal is not here. So I will request Dr. Sachin Kumar. So Dr. Sachin Kumar is going to present on teaching clinical skills to undergraduates in a busy OPD. So in the meantime, I'll request our next speaker, Dr. Sunil Kumar. We will be calling you on time. Yeah, Dr. Sachin, please.
नहीं आया तो सर्च करना पड़ेगा उसमें यूजी करके अंडरग्रेजुएट्स के लिए सर्च कीजिए ना अंडरग्रेजुएट स्टडी आ जाएगा यूजी सर्च कीजिए डलवा चुके थे अंडरग्रेजुएट्स अंडरग्रेजुएट जारी ना मिल गया हाँ कर दीजिए डायरेक्टली हेलो ये क्लिक होगा ना अप डाउन कैसे होगा स्क्रॉल कैसे होगा ये नेक्स्ट ठीक 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 हेलो गुड मॉर्निंग एवरीवन माई सेल्फ डॉक्टर सचिन कुमार एसोसिएट प्रोफेसर एंड हेड ऑफ डिपार्टमेंट NMCH पटना टुडेज माई टॉपिक presentation is teaching clinical skills to undergraduates in a busy OPD. Now the topics looks very simple, but I'm afraid it is not so because a very busy OPD is very important for teaching undergraduates. Then what undergraduates needs? They need to see real patients, real science, so that they develop real clinical reasoning. Otherwise, they lack clinical skills, so that we lack good doctors in future. Then what to do? We have to do hand-on examination under supervision. Then we have to receive feedback, which is very important. It is immediate or specific or constructive. Then, so what OPD has to offer? Beyond examination skills, OPD also offer how to communicate with patient, and how to take consent or empathize with patient, and also they learn professional behavior. After all, we also learned most by watching our seniors. What is the main problem or barrier we face in OPD? First of all, a heavy OPD load, then limited bedside exposure. Students observe, but they rarely examine. So their clinical skills remain weak. We should not forget, OPD is very busy, but it is the best classroom. And a very small effort can make a very big impact. Then what is the solution? What I personally do in my OPD, mainly I focus on 1 or 2 clinical skill, and for 2 to 5 minutes. I personally do the 5-minute OPD teaching model, which is a simple and repeatable structure. First, identify a teachable patient, not a treatable patient. Then demonstrate one clinical sign. Let a student examine and reinforce the key point and ask one question. This all thing can be done without stopping OPD. what is the home assist for the BG OPD is not a barrier. Clinical teaching does not need extra time. A small consistent effort can create the confident doctors. If we don't teach clinical skills in OPD, there is nowhere else where we can teach them or learn, our students can learn them. Thank you.
So, thank you, Dr. Sachin. Now, I would like to request Dr. Sunil Kumar, please come up on the stage to present Conquering Hard Cataract.
Sir, actually, if you, it's normal for your PGs to present a case in front of you. So even with every case, what I do exactly is with every case, I do a teaching over there only. That is a way, because until unless, and you should not attend to them until and unless they are giving the full history. They are actually, you first tell them ki kya hai, elicit the signs and everything. If they are wrong, you have to correct that. So that thing we have to do.
About 15-20 students come in OPD. We don't take care of him. They gone absent.
That's not happening with us. We do it because we have to do it. Each and every patient who has whatever you're feeling is fit for the UG, we have to do that. The clinical science artist. That's the only thing that is
In OPD, I think patient is very tenuous, ma'am. They distribute, okay, ma'am.
To distribute the work. Like if the head, whoever is the unit head is actually attending to the teaching part, and in the meantime, whenever the PGs are giving the cases and presenting the cases, we go to them, attend to them, and get back to our teaching work. So that's
how communicate with a patient. Student also see how you talk with the patient, how empathize, and how I am take care to the patient, ma'am. This is also very important.
That's a great discussion on teaching part, and thanks ma'am for enlightening us. So now Dr. Sunil Kumar, he is HOD of Rio RIMS, and he is going to present on Conquering Hard Cataract.
So good morning to all. So no financial interest. So Phaco in hard brown cataract poses a specific and difficult challenges because of the poor red glow, difficult rexes and hydro procedures. And there is a hard, compact and large nucleus and sometimes lazy posterior plate. And there is no epinuclear plate of the cushions, and sometimes there could be the poor pupillary dilatation and zonal instability. So pre-operative evaluation is very important to look for the grade of the cataract, what is the depth of the AC, whether we achieve the poor pupillary dilatations or not, any comorbidities, and also we have to look for the status of the corneal endothelium. And the intraoperative strategy which I follow is the staining of the entry capsule is important. Adequate size capsular axis around 5.5 to 5.75 millimeter axis. Use of the dispersive viscoelastic soft cell technique. And my go-to technique in these hard cataracts are generally central to make the central crater and do the direct chop. And use of the long sharp chopper and more tip exposure helps. And there should be complete separation of the posterior plate and make multiple soft chops and generous use of the viscoelastics during the surgery. So this is the small video clip. So this is the hard brown cataract. This is the almost black cataract. So first is the staining of the capsule. You can see the uniform staining, and then we have to make the rexes minimum 5.5 millimeter rexes. We should avoid the baby rexes in these cases. And also we should avoid the very large rexes as well, because we have to cover the optic of the IOLs. And very gentle multi-quadrant hydro procedures. And generally we make the small crater. So we have the better hold. And you can see that exposure of the tip is more in the hard cataract. And the power here I am using is only 80% power. And vacuum is 500 and flow rate is 50. Or sometimes I use the 48. So you can see we are doing the multiple sub chops. And after this sub chop, the nucleus piece, if they are free, they easily comes to the Phaco tips. And we should avoid going to the periphery with this tip. We have to just keep it the center of the Phaco tip, and this fragments will follow automatically because of the high flow rate. And this is just normal bimanual IA, and this is the implantation of the single piece IOL. This is another case. Sorry. So this is again very hard cataract. Here the pupil dilatation is not very great, but there is minimum 6 mm dilatation of the pupil. Again we have to make the rhexis of 5.5 millimeter. Generally I make the rhexis with this 26 gauge cystitome with the main force. Again very gentle hydrodissection. So this is the first chop. So the first chop should go beyond the midline at least, and then make the multiple sub chop. And again here we have to do the Phaco procedure in the central safe zone. We have to just keep the Phaco tip in the center, and because of the high flow rate and high vacuum, these fragments will follow automatically to the tip. So we don't need to change to the nucleus. So pupil is gradually becoming smaller, but not problem. So and this is the simple bimanual hydrocortical aspiration and the implantation of the single piece IOL in the bag. This is the last video. Again this is the white cataract with the mature nucleus. Again similar surgery. The rhexis should be of adequate size. In the white cataract, the nucleus is normally not very hard, other like the brown cataract or black cataract. So again here I am using the power of the 80% vacuum 475 and flow rate of 48. And you can see how beautiful the chopping occurs. And each nucleus should be divided minimum into 3 parts. And once the division is complete, again the fragments will follow very beautifully to the Phaco tips. Then this is the cortical aspiration. Very minimum cortex is there. So go to the implantation of the single piece IOL. So just to conclude this detailed pre-op evaluation and using the right intraoperative strategy, Phaco can be done safely in this very hard brown cataract. So thank you very much for the patience hearing.
थैंक यू डॉक्टर सुनील सर, आपका चॉपिंग देख के डॉक्टर कश्यप सर ने कहा कि क्या बात है. सो आई विल बी इनवाइटिंग द नेक्स्ट स्पीकर डॉक्टर सोनी सिन्हा. इन द मीन टाइम वुड लाइक टू लिसन फ्रॉम डॉक्टर कश्यप सर टू ऐड समथिंग रिगार्डिंग चॉपिंग एंड वी हैव सीन योर लाइव सर्जरी ऑलवेज. इट्स वंडरफुल.
Friends, the surgery which you have seen is not easy. ये डॉक्टर सुनील ही कर सकते. He is an expert. एक्सपर्ट के अगर भी ऊपर होता है तो वो ये बंदा है. It's not easy, it's not easy. And pupil dilatation has to be sufficient. You should know what he said is adequate rhexis. What is adequate rhexis? He knows it. What is 5.5? He knows it. He has done a fantastic surgery. इसमें और क्या कोई ऐड कर सकता है? कुछ नहीं. Thank you, sir.
Thank you, sir. So in the meantime, next speaker will be Dr. N.D. Mishra. Are you there in the hall? may not be. I think Dr. N.D. Misra is absent. So we'll be going for Dr. Sunil Kumar Singh. Next.
So let's go a bit retro and do some, talk about something that nearly all of us are doing, and this is my message to comprehensive ophthalmologists, how I have done it my way over the years, and some pointers from what I've gleaned from my mentors in glaucoma. So precautions in incisional glaucoma surgery. It has been associated with significant morbidity right from its inception, and a fine balance is needed to achieve a successful outcome with least possible complications. So it starts with the approach when you counsel the patient about the aims, complications, and visual outcome, and do not raise the hopes of the patient, about vision improvement. Of course, we need a systemically stable patient, and anti-platelet medication to be discontinued about 3 to 5 days a priori, and treat all inflammation, that is to prevent scarring in the post-op period, treat all the, pointers of neovascular glaucoma by doing a PRP first, or maybe anti-VEGF2, switch over to oral CA inhibitors instead of topicals, and have a generally normalized IOP as far as possible. There are many options and strategies, but we are talking about TRAB as of now, and it's important to identify the high-risk eyes, about high myopes children, and about cases with raised episcleral venous pressure and anophthalmos, as also the ones who are going prone to too much of scarring. So if you go about with intraoperative precautions, for the exposure, the speculum has to be applied judiciously with the least amount of pressure, the superior rectus bridal suture to be taken very carefully without causing any hematoma, preferably with a 4-0 silk. And then if you are opting for a limbal base, then in that case a peripheral corneal suture which should be 2/3 deep, because a too superficial will cut through and too deep one will cause an shallowing with a full penetration. So then now location of the bleb is superior or superior sparing, in which case you can do a superior nasal, which again affords easy access and affords more space for elevated blebs. Is it in between the recti muscles, and affords a better protection without shadows from the basal iridotomy that we'll be doing later on. And of course, you have to avoid all scarred conjunctiva and handle conjunctiva very judiciously, maybe with a cotton tip, but avoid the thin sclerae and the perforator vessels, which will cause a lot of bleeding. So if you're doing a phonics base flap, it is better to have a 2.5 millimeter, 1 to 2.5 millimeter fringe with the wise technique, and then have as small a flap as possible to begin with, while the posterior dissection has to be rather, larger for a better exposure and easier closure in this case. Now we have to excise all the pre-existing scar tissue, if any, and do as less a manipulation as possible with a gentle handling, with non-tooth forceps, a blunt dissection with less taking care not to buttonhole the conjunctiva, and defining the edges of the adjacent recti helps to maintain the orientation and accurate placement of the scleral flap. Again, a wet field cautery and a judicious amount of cautery, not over cauterizing, causing inflammation or necrosis, or not as least as causing a lot of bleeding and later on fibrosis is needed. Antifibrotics used is of course done with previously failed glaucoma surgery, previous intraocular surgeries, or in races with high scar tendency or in childhood and secondary glaucomas, and not be used generally with primary in a young patient with myopia. So the application of wound modulators again is optional, whether you inject it or you actually make a conjunctival flap and do a subconjunctival application, in which case you may use a polyvinyl sponge tipped in 0.2 milligram per ml of this MMC or fluorouracil, taking care not to touch the edges of the conjunctiva with this flap, and with the thorough irrigation of the isotonic solution. At the same time, when you're fashioning the scleral flap, it's important to use a very sharp blade and have a minimal size of the scleral flap as necessary, and the depth of the scleral flap should be about 1/3 to half to offer enough resistance for the aqueous humor outflow. Again, it's best to just lift up the flap at the apex, and you take care to look at the fibers that are visible, and then tear and cut at the same time, reflect the flap upwards and outwards towards the center of the cornea with the blunt forceps and the high magnification and full hemostasis of the bed with a dry sponge every now and then. And the anterior limit of the scleral flap has to fall short of the actually limbus, so to have a more posteriorly draining bleb and preserving the tenon's insertion avoids this anterior dissection or a cystic bleb which would overhang the cornea later on. And then you have the dissection into the clear cornea in the center, especially in narrow angles. You have to avoid the injury to the ciliary body. And then you do either, the block disc sclerectomy, either with the scissors, in which case you use a very sharp venous scissors, or you might even go for Achilles punch, where you make an ab into external entry into the AC. In all cases, you have to be very careful to hold the scleral punch as vertically as possible so that you can avoid, make an opening without having any shelving inside. And all cases, you have to keep the AC deep at all times during surgery, and for the next step, ready to reduce the hypertony time. And iridectomy has to be done, keeping in mind the size of the inner ostium that you're going to create, having the venous scissors aligned with the limbus for later, orientation of the iridotomy, and repositioning it by irrigating the sclerotomic site or gently stroking the cornea towards the pupil with the blunt instrument. A closure of the scleral flap has to be necessarily not very tight and not very aligned. And the number of sutures can be titrated according to the size of the flap. Pre-placed sutures always help to shorten the hypertony time. And once you suture it, the AC is deepened by BSS, and the IPH can be monitored and titrated to check the filtration. It's always helpful to have a releasable suture, and it's important to have the apical suture as the releasable suture, preferably when the second bite goes through the base of the flap as a partial thickness, and the free end of the loop knot is trimmed and buried into the cornea or the sclera for later release. The conjunctival closure in a limbal blade flap, where you have followed the Weiss technique with a conjunctival fringe, is relatively straightforward. When you have a running horizontal matter suture in 1 or 2 layers, or you can even have a phonics-based suture, in which case 2 winged sutures at the edges to stretch the anterior edge of the conjunctiva slightly to overlap the cornea is sufficient to have a watertight closure as much as possible. And it's important to use a round-bodied needle so that you don't traumatize the conjunctiva in the bargain. It's always helpful to have a corneal paracentesis, or through which even an AC infusion or ACM can be put in to form the anterior chamber, and not only at the end of the surgery, but keep it formed throughout the surgery. At the same time, it helps iridotomy, because if you have an infusion running, yeah, sure. You have always, an iridotomy, which is an iris which is easily prolapsed through. And so the take-home message is that the glaucoma surgery demands care and caution for successful initial outcome, and there's a need for long-term follow-up to detect and manage delayed complications to preserve the vision. Thank you.
Thank you, ma'am. In the meantime, may I call Dr. Sunil Kumar Singh to present his talk, and I'll request all the speakers to follow the time. That's great. And ma'am, it's a very nice, precise presentation on all the steps, and we all understand surgical steps are very important in glaucoma surgery, and so also the follow-up. So if the patient is not going to follow up every nice step, they fail.
Our would-be health minister.
Sir. Thank you, Jhoscon, for giving me this opportunity, and happy Mahashivratri to all. And really, seeing the gender inequality of chairpersons, I can say that women empowerment is at its peak in Jharkhand, because 80% out of 8 out of 10 is gender inequality. You take it as a protest or whatever it is, it should be a little bit more even. Anyway, thank you. And about, sir, you were commenting on sir's operation, surgery. Yes, I agree. The people should be dilated, but while comment on, add on one thing. He chop thodi kasai numa honi chahiye usme, the way he was having a chop. Thank you very much. हमको बताना पड़ेगा यार, इसको हमको कहाँ से ऊपर नीचे हो, बताओ कहाँ से, नहीं उसके पहले वाला करो. My topic is, बढ़ना इससे ना, My topic is outcome of customized toric intraocular lens for cataract associated with high astigmatism, a case series. I am Dr. Sunil from Sanjeevani Eye Hospital, Patna. Astigmatism is an optical disorder, you all know. It can decrease visual acuity, it can decrease contrast sensitivity, and prevalence of astigmatism is nearly 10 to 13% of the refractive errors. Classification: spherical cornea or lens, the curvature is same in all meridians. Astigmatism, in present there are two principal meridians, one with greatest curvature, steepest, one with least curvature, flattest. Regular astigmatism is with the rule astigmatism, against the rule astigmatism, or astigmatism. Regular is when the two principal meridians are 90 degrees apart. Irregular is whenever the two principal meridians are not symmetric, they do not lie 90 degrees apart, and the astigmatism is considered irregular. So methods of correcting: toric IOLs, limber relaxing incisions, and two-stage procedure with excimer laser. I'll say that toric IOL is the most predictable. It's the procedure of choice to correct corneal astigmatism of one diopter or more in cases undergoing cataract surgeries. But I will talk about customized toric IOL. The patient selections with ideal patient regular astigmatism, but still good outcomes in mild central irregular astigmatism, and I will talk here about pellucid marginal degenerations and post-corneal transplant. Workup, as you see, it's complete ocular examination, preoperative astigmatism measurements, IOL power calculation, IOL selection, marking techniques, and residual astigmatism. You see that include cases with high astigmatism. And now the applications of toric IOLs are expanding to include cases with high astigmatism, irregular astigmatism, corneal ectatic disorders, and post-keratoplasty cases. So you need to have a customized toric IOLs. Care group, they make, we did study here, the cases series is 5 eyes of, with PMCD with significant, one with irregular astigmatism. Regular toric IOLs would correct astigmatism only up to 6 diopters in the IOL plane, but higher astigmatism would require customized toric IOLs, so above 6 diopters. Case series, case 1 is 65-year-old male, there was no history of corneal contact lens usage, slit lamp. So you can see that against the rule astigmatism of 12.1 diopters, with the crab claw configuration, classical of pellucid marginal degenerations, and against the rule again 12.3, the left eye, both eyes with significant corneal cataract. Surgery: right eye was customized 16.5 steep axis of 170 degree through temporal incision, followed by left eye with, you can see, 18 diopter T20 steep axis at 5 degree through temporal incision. You can see the lens, ultimate smart lens. The result: a right eye you can achieve up to 6/9 post-op. Left eye again 6/9. There is a slight amount of cylinder, but then the visual acuity is 6/9 post-op. Now case 2 is 59-year-old female. There was no history clamp, clear corneal with significant PSC in both eye. Can again see 4.59 diopters, 9.8. Both eye with significant PMCD with significant posterior subcapsular cataract. Surgery was, you can see the lens. This, even with on the right eye, the vision is 6/6 BCVA post-op. Left eye is BCVA 6/9, but there is minus 3.75 stimuli because of the corneal scarring. But post-op, it was okay. Now this case 3 has a blunt trauma, right eye 6 months back, and the left eye was clear lens, right eye was subluxated roseate cataract. Subluxated it was. You can again see crab claw pattern, PMCD diagnostic, against the rule with 10.3 diopters. Both eye PMCD with right eye traumatic subluxated. Right eye Phaco with implantation of customized eye-enhanced toric IOL in the bag, CTR and CTS assisted. Left eye was for left focal contact lens trial. This you see the right eye, the 6/60, the post-op was 6/6. Left eye, you can see it was with contact lens trial. Toric IOL is not advisable in highly irregular astigmatism. You can see here, the case 4 was irregular astigmatism. History of right eye keratitis 1 year back, which is healed now, right eye void cataract. Right eye white cataract with healed keratitis with highly irregular astigmatism on topography. BCVA was 6/60 minus 4 diopter cylindrical. It did not improve, so the take-home message is it's not for irregular astigmatism. The result from our case series demonstrate that customized toric IOL is a safe, predictable, and effective surgical option in non-progressive PMCD. However, need more cases, long-term follow-up, change in corrected distant visual acuity, changes in astigmatism, eye rotation, degradation of quality of vision, and this is the thing, and thank you very much for a patient hearing. I hope I was on time, because I was fearing that you will say that time is up. Thank you very much.
Talked about irregular astigmatism in the viral keratitis cases. So if you're putting ILs over there, I mean torics over there, then in that case, ma'am, sir, in a year, at least they have 3 to 4 recurrent episodes of keratitis. So what about the astigmatism? I mean, there'll be changes in that.
That is the take-home message. I did not advise that. You should not do. You should not do.
Thank you, sir, for the nice presentation. So, the next speaker is Dr. Ravi Ranjan. Dr. Vibhuti, sir, is a very prominent cataract surgeon in Jamshedpur. So, I would like to listen from you, your experience of customized toric lens.
I've used that Indian customized toric lenses manufactured by CARE, and I'm very happy with the results. The results are very good, and we must give it a try actually, whatever is there, because even if it is not bringing the toricity to zero or the astigmatism to zero level, but it significantly reduces the cylindrical power and does give the patients a very, many times the patient gets a wow effect because they have not been seeing things clearly, but with that toric lens, a significant amount of cylindrical power, it comes down, and the patient is very happy. I have never seen any patient unhappy after giving him a very high, correcting a very high cylindrical power with a customized toric lens.
So small powers, very high is all right.
Small powers, the toric lens that you, in your practice you can see that generally initially we used to use toric lenses beyond 1.5 cylindrical power, but nowadays we are seeing that even 0.75 astigmatism also is being corrected with toric lenses, and the patients are very happy. Toric lens.
I was asking about these conditions. So talked about those conditions. If there is low astigmatic power, then what? Should we go for the multifocal ILs?
No, not multifocal. I don't use multifocal in such irregular astigmatic cases.
Okay, thank you, sir. Please, yours.
Good afternoon all. Coming to Jharkhand is like coming home. I have done my MBBS, MS, all from RMCH. My teacher, Dr. Rajiv sir, is here. Sir, pranam. My topic for today is, could corneal ulcer be a cause of dacryocystitis? It is again against the popular belief, no financial interest. Corneal ulcer caused by infection is one of the leading cause of blindness worldwide. Second only to cataract, and particularly common in developing countries like India. And the objective of this study is to compare the risk of dacryocystitis among patients with corneal ulcer to the general population. And a study design is prospective, non-controlled case series. And the total 56 patients, and the study was conducted between February 2022 to September 2024 in private hospital of Bihar. And the inclusion criteria were patient having corneal ulcer in one eye and no history of any lacrimal pathology. And before any medical treatment, the syringing of the lacrimal drainage system with moxifloxacin eye drop to determine any
point of obstruction, and the medical treatment of the corneal ulcer depends upon their clinical and pathogenic diagnosis, and the surgical treatment was performed when the infection could not be controlled by the medical treatment with the help of cornea specialists attached to my hospital. And if there are symptoms of dacryocystitis, systemic antibiotic is started, and if there is still no improvement since 4 to 5 weeks, we perform DCR. And the outcome after 4 to 5 weeks of DCR, that is fantastic, and this is in the first case, and this is in the second case, that is third case, and that is fourth case. And the result is among 56 patients, 5 were diagnosed with dacryocystitis at the end of 4 to 5 weeks. One case was successfully treated with medical treatment, and rest 4 I have seen already results of all 4. And the only limited number of published studies indicate a high risk of dacryocystitis due to corneal ulcers. And the and in the North Indian study, only one study I have got, and that is prevalence of dacryocystitis was 19.5 per 10,000 patients, and the patient of acquired dacryocystitis are 10,000 per patients. 95% CA is 1.15%. And another study is from North America, and that is population-based study by Woog MD. The average annual incidence of systemic acquired lacrimal outflow obstruction in people above the age of 5 was found only 0.03%. And here, our data shows that is 8.93% of the eyes with corneal ulcer suffered with dacryocystitis. And it is a comparison of the incidence of dacryocystitis. Here the bar graph comparing the incidence of dacryocystitis between the general population and the patient with corneal ulcer. The bar represents the observed incidence percentage, and the error bar indicates 95% confidence interval. And now we come to the odds ratio calculation. I'm not going in detail, and that is calculated odds ratio is 65.25%. And interpretation of that is the patient with corneal ulcer are over 65 times more likely to develop dacryocystitis compared to the general population. And here is the forest plot illustrating the odds ratio for the developing dacryocystitis in corneal ulcer patient compared to the general population, and the horizontal bar represents the confidence interval for the odds ratios. And the general population is used as a reference group in this study. And the more importantly, patient in our study had no history of dacryocystitis. More importantly, patient in our study had no history of dacryocystitis previously. That is, they were diagnosed with dacryocystitis for the first time only after 3 to 4 weeks of corneal ulcer. And the conclusion is that in our study, observed proportion was 8.93%, that is 5 out of 56, and the reported incidence in general population is 0.15%, and the confidence interval for observed proportion is 2.946% to 19.58%, and that confirms observed proportion is significantly higher. And the incidence of dacryocystitis among patients with corneal ulcer is significantly higher than the reported incidence in the general population, that is 1.5%, and in our study that is 8.93%. And to the best of my knowledge, corneal ulcer can lead to the obstruction of the lacrimal duct, particularly in the lower canalicular region, causing dacryocystitis. Although various studies have been conducted on the treatment of dacryocystitis and corneal ulcers, the scientific community has not yet recognized the association between corneal ulcer and the lacrimal duct obstruction, that is dacryocystitis. And that are my references. And thank you for patience listening.
Thank you, sir, for the wonderful study. So now I would like to request our next speaker, Dr. Sudhir Kumar, to come up on the stage. In the meantime, this association of dacryocystitis in corneal ulcer patient, because Dr. Renu, you have got a very long experience. So how is your experience in this combination?
Dacryocystitis with corneal ulcer patients, we don't have many experience like sir, so his presentation is very nice, and I also learned many things from his experience. Thank you.
That was a very nice study, sir. आप ये पता करने चले थे कि मुर्गी पहले आई कि अंडा?
खाना लेकिन दोनों को है.
There was one factor which could have been seen, corneal ulcer as well as chronic or adacris cystitis, both are diseases belonging to low socioeconomic status.
Exactly.
तो मे बी वो भी एक फैक्टर है जो कंट्रीब्यूट कर रहा होगा.
हमने तो वो बताया ना कि हमारे कोई वैसा adacris cystitis नहीं था before corneal ulcer. That is the point.
That's a very unique observation, sir. Thank you.
Ravi.
Very nice presentation. So do you really advise us to do kind of a syringing in all cases of probably corneal ulcer or non-healing corneal ulcer?
Yes, it is the dictum, sir.
Yeah, that is the message to be conveyed, yeah?
Yes, sir. My observation is different, sir. That's why I am there. Yes. Yes. Popular belief was against it. Thank you. हाँ सर, ये तो है ही सर, dictum.
शुरू करें. Thank you, Jhoscon, for giving me this opportunity. I am going to discuss about low vacuum phacoemulsification for soft and moderate grade of cataract. And we all know that there has always been a need for a fine balance between fast surgery and safe surgery. That is quality of surgery. Fast surgery gives more income to the surgeon, while high quality surgery gives a wow factor for the patients. And fast surgery needs high flow fluidics parameters, and this may cause unstable anterior chamber, corneal edema, increased inflammation, more incidence of PCR and iris damage. So another strategy is low flow phaco, which gives better early result with clearer cornea, less inflammation and less chance of accidents, but at the cost of longer duration of surgery, which can be frustrating for the surgeon as well as for the patient. And now it has been established its role in compromised, that is low vacuum phaco has already established its effect in compromised cornea, zonular dialysis, glaucoma and high myopia, etc. So could there be any optimum way to balance between the safety and time taken in phaco? To compare between high fluidics and low fluidics phacoemulsification, clarity of cornea, inflammation and complication, I did a small study in my setup with standard phaco steps, and the vacuum and AFR and power was arbitrarily fixed for high vacuum and low vacuum. And the mean results were here they are a small study. I will discuss in the discussion part itself. And in the current study, there was an increase in CCT and inflammation in early post-operative days, all well settled in the end of 4 weeks, at the end of 4 weeks. And concept of slow motion phacoemulsification was propagated by Osher in early 70s and 80s. Phaco machines at that time were primitive, and high fluidics caused severe endothelial cell loss, increased inflammation and other complication. उस समय जब ओशर जब आते हैं तो उस समय तक फाइको पावर जो लोग यूज कर रहे थे एक्सीडेंट ही ज़्यादा हो रहा था, क्योंकि उस समय का मशीन बहुत ही अनस्टेबल हुआ करता था. His studies where he used lower aspiration rate, a lower vacuum and lower ultrasonic power, which revolutionized early post-operative outcome, and most of them had very good visual acuity on first post-op day. And a study by Baradar and Rafi et al. Showed no difference in endothelial cell loss between high and low fluid hydrodynamics parameters, but there was strong correlation between ultrasound energy and endothelial cell loss. Another study by Abhay Basawala et al. Showed that low fluidics parameters led to lower increase in CCT and decreased inflammation and clearer cornea in early post-operative days. but studies by Sudeep Das et al. And Anthony Chang found no difference in endothelial cell density, CCT, and central macular thickness, and these may be associated with increasing experience with the Phaco surgeon and improvement in the machine. A study by Sabine MS et al. Suggested quadrant removal is more efficient with high fluidics, that too without more tissue loss. And a meta-analysis by Pochin also found no difference in anatomical outcome like CCT and endothelial cell loss. But he found greater increase in CMT and CME in high fluidics group. And this could be due to transient anoxia during the surgery because of high intraoperative IOP and greater fluctuation in IOP, leading to oxidative stress to the retinal tissue. And the limitation of my study was that it was a very small sample size, endothelial count could not be done. And so based on this, I could conclude that both the strategy of Phaco emulsification for mild and moderate grade nucleus is safe and acceptable for the patient as well as surgeon. Strategy should be chosen based on the man and the machine. The strategy should also be based on other associated factors as health of the cornea, size of the pupil, granular status, retinal status, and glaucoma. Optimum results can easily be achieved by changing strategy during the surgery itself, as during chopping low parameters in soft cataract and then switching to high parameters to save time in quadrant removal. Thank you.
Thank you, sir. Sir, can we go to your next topic also? Yeah. So the next topic is also of Dr. Sudhir Kumar, sir. So it's on beyond basic vision, modern day monofocal in cataract surgery. So until he will be preparing, Dr. Shruti, what is your experience on the different parameters for Phaco and the keratitis?
So I think as sir concluded, we should not chase behind speed. It should come with the experience
also.
And whatever works, whatever setting works in each of our hands, I think
exactly
that's best. So
you can.
There is no one thing
exactly
suits for all formula.
But here I want to highlight that going to higher pressure not necessarily increases the chance of complication. So you can amalgamate both slow fluidics in chopping, while in quadrant removal you can go for, which is much more safer step, you can go for higher fluidics.
So sometimes in very soft cataract, Phaco 3 may be sufficient to emulsify the things.
और क्या हम तो बेसिकली बहुत लो फैको में ही इनफैक्ट इसको स्कल्पिंग में ही बोलते हैं, उसमें लो सॉफ्ट कैटरेक्ट को चॉप कर लेते हैं, उसके बाद सीधे क्वाड्रेंट रिमूवल में चले जाते हैं, उसमें करने का जरूरत नहीं पड़ता है स्कल्पिंग. माय नेक्स्ट टॉपिक इज बियॉन्ड बेसिक विजन. एक्चुअली जब हम लोग ओपीडी के प्रोसेस में रहते हैं तो पेशेंट लास्ट में पूछता है सर कौन सा लेंस सबसे अच्छा होगा मेरे लिए. एक्चुअली इसमें दो क्वेश्चन निहित है कि टेक्नोलॉजी कौन सा सबसे अच्छा है और दूसरा कि क्या मैं उस टेक्नोलॉजी को अफोर्ड कर सकता हूं. तो क्योंकि टेक्नोलॉजी का प्राइस होता है, किसी न किसी को देना होगा, तो जवाब उसका बहुत सीधा नहीं भी हो सकता है. तो अभी जैसे सबसे महंगा लेंस आपका ट्राइफोकल्स है, तो क्या उसको सबसे अच्छा लेंस बोल सकते हैं या मोनोफोकस को अच्छा लेंस बोलते हैं. तो इस पर तो एक बार हम लोग नज़र डालते हैं. डेवलपमेंट हुआ इस तरह से कि जितना भी पुराना लेंस है ऑल वेयर स्फेरिक लेंस है, नॉट ए स्फेरिक. स्फेरिक लेंसेज का मतलब फोकल लेंथ, फोकस पॉइंट एक जगह नहीं था, तो उससे क्या होता था कि एक डेप्थ ऑफ परसेप्शन मिलता था. बट ओवर ए पीरियड ऑफ टाइम द स्फेरिक लेंसेज ए स्फेरिक में चेंज हो गया एंड फोकल पॉइंट हो गया. तो उसका एडवांटेज ये मिला कि क्रिस्प हो गया विजन, लेकिन उसका जो डेप्थ ऑफ परसेप्शन भी था वो कम जाता है. तो इसको कई तरह से लोगों ने एड्रेस करने की कोशिश किया. उसमें एक मोनो विजन का कंसेप्ट है, जिसका मतलब था कि थोड़ा सा ओवर करेक्ट कर दें तो एक आंख में थोड़ा ओवर करेक्टेड रहेगा तो थोड़ा सा डेप्थ ऑफ बाइनोकुलर डेप्थ ऑफ विजन मिल जाएगा. लेकिन विद डेवलपमेंट ऑफ टेक्नोलॉजी देयर कैन जोनल और नॉन डिफ्रैक्टिव ऑप्टिक्स. द एडवांटेज ऑफ जोनल डिजाइन is that they can have a good near vision also, but the disadvantage is zonal design causes abrupt change in power, but it has a low modulation transfer factor. इसके बारे में हम लोग डिस्कस करेंगे. And another lens which is refractive technology based on continuous higher order aspheric, and there is no ring. So a good monofocal में हम क्या क्या चीज़ चाहते हैं? High quality of picture, which is यहाँ MTF, और कुछ हद तक intermediate day-to-day work का मिल जाए, and so there should be no dysphotopsia and low incidence of PCO, hydrophobic square edge वगैरह. तो इंटरमीडिएट वर्ड बोलते हैं ना लोग कि इंटरमीडिएट विजन का क्या मतलब है? ये कोई आर्बिटरी चीज़ है. हम डे टू डे वर्क कर सकते हैं नियर का, उसी को इंटरमीडिएट बोल सकते हैं. इसको सेंटीमीटर्स में नापना साइंटिफिक नहीं है और रियल लाइफ में नहीं है. तो हम इसमें 2-4 फिजिक्स का वर्ड हम लेंगे ना. कॉन्ट्रास्ट थ्रेशोल्ड इज द स्मॉलेस्ट डिफरेंस इन ब्लैक एंड व्हाइट ह्यू दैट कैन बी डिसर्न्ड, एंड कंट्रास्ट सेंसिटिविटी इज इसका रिवर्स है. मतलब कि स्मॉलेस्ट जो कर सकते हैं इसका डिसर्न, इसका मतलब उसका हाई का कंट्रास्ट सेंसिटिविटी है उसका. और कंट्रास्ट सेंसिटिविटी नापने के लिए बहुत सारा हमारे पास चार्ट्स है, जिसमें एक है कि इक्वल्स स्पेशियल बोलते हैं इसको. एक लाइन से दूसरे लाइन का जो डिफरेंस है साइकिल्स पर मिनट, वो अगर कम है तो लो स्पेशियल है, और ज़्यादा है तो उल्टा बोल रहे हैं हम. लो स्पेशियल का मतलब हुआ कि ज़्यादा दूर दूर और बड़ा बड़ा है, और छोटा छोटा है तो हाई स्पेशियल कंट्रास्ट सेंसिटिविटी है. लेकिन इससे पूरा बात क्लियर नहीं होता है, क्योंकि रियल लाइफ में कुछ उस तरह का हम लोग देखते हैं. रियल लाइफ में कोई एक पेड़ देख रहे हैं और इसमें कितना डिटेलिंग हम देख सकते हैं, ये बेसिकली हमको देखना है. और इस तरह का सारा चीज़ को जब मिला देते हैं कंट्रास्ट का, तब उसको मॉड्यूलेशन ट्रांसफर फंक्शन बोलते हैं. और ये कंसेप्ट ही आधार बनता है हमारा आने वाला लेंस को ये करने के लिए, कंपेयर करने के लिए. तो अगर MTF इज लेस देन 0.3 इट इज कॉल्ड पुअर, एंड व्हेन इट इज जो नॉर्मल बच्चों में होता है दैट इज 100%. यहाँ पर एक पिक्चर है जो आई ट्रेस का लिया हुआ. ये एक नॉर्मल बच्चा का है, येलो वाला है, इसमें नहीं आ रहा, एक मिनट. ये येलो लाइन जो है ये एक नॉर्मल यंग पेशेंट का है, और ये एक लेस देन 40% वाला जो वेरी पुअर ग्रेड में आता है. लेकिन जब हम बहुत सारा लेंस लगाते हैं जिसमें खास करके ट्राइफोकल्स, तो ये MTF सीधे पुअर जोन में आ जाता है. तो इसमें एक और कंसेप्ट लेते हैं. जब मोनोफोकल लगाते हैं तो विजन डिस्टेंस का बढ़िया है, लेकिन धीरे धीरे नज़दीक का खराब हो जाता है. जबकि एक यंग चाइल्ड में वो दूर के लिए भी 100% MTF है और नज़दीक के लिए भी है. तो यही चीज़ आप ट्राइफोकल्स में पाते हैं. तो क्या दोनों इक्वल है? यंग चाइल्ड और सिनर्जी का जो ग्रेडिंग है वो इक्वल है, ऐसा लग सकता है. लेकिन जब हम MTF पर जाते हैं तो फॉर यंग चाइल्ड MTF for all different distances are around 100%. But in a patient with having some near vision or intermediate, in a lens which gives near vision or intermediate vision has low MTF. इसका मतलब दिखेगा जरूर उसको, लेकिन quality of vision गिर जाएगा. So it is always a trade-off between range and quality of vision in IOLs. So ये थोड़ा सा ज़्यादा हो गया है. तो इस तरह से we can have a parameter which one should always see whether I am getting good vision or the patient requires good vision, good quality of vision, not the range of vision. Because वहाँ पर आप फंस सकते हैं. बहुत बार ट्राइफोकल्स केवल एपिथेलियल डिफेक्ट से इतना बैड इफेक्ट देता है पेशेंट को कि पेशेंट विल बी अनहैप्पी. अभी तो मैंने डिस्फोटोप्सिया विद ट्राइफोकल्स का डिस्कशन भी नहीं किया. अभी तो जस्ट केवल नेचर ऑफ द लाइट ट्रांसमिशन का बात हो रहा था. विद दिस आई से थैंक यू.
Thank you, sir, for sharing your experience with Technis Eye Hands. I would like to request all the discussants who have already using this IOL if they would like to share their experience. And in the meantime, the next speaker, please come on the desk, Dr. Pratik Nishant, please. So, any one of you using Technis iHands, your experience, Dr. Vibhuti sir, aapka.
Yes, I have used Technis iHands lens in quite a good number, and the results are very good. At least the patient, none of the patients complained about the, like everybody was happy. It's difficult in our OPD setup to examine the contrast and other things for every patient, but the patients were very happy, and they did have some amount of intermediate vision also, without any complaint that in dim light they are having problem or the quality of vision is compromised in any way.
I have used Ray 1 EMV and Technis also, and more or less I found the results in my hand as equal, and even for the near and the requirement of power or addition power reduced to 1.5 to 1.75 in both the lenses.
So good afternoon, ladies and gentlemen, esteemed panel, members of the audience. Thank you, Jhoscon and the entire scientific committee for inviting me here. I'm going to speak on perils of artificial intelligence in ophthalmology. I'm Dr. Pratik from IJIMS Patna. I have no financial interests. So artificial intelligence based ophthalmology devices have come in vogue, and there is commercialization and promotion of these devices as screening tools for diabetic retinopathy, age-related macular degeneration and glaucoma and so on. Recently, a lot of softwares have been approved by the CDSCO for these indications, and others are in pipeline. For example, Remedio NM10 fundus on phone device and Medios DRX AI algorithms are made in India devices and softwares which are working on the artificial intelligence technology. Currently, they are supported by 50 plus peer-reviewed publications and have the potential for widespread use by eye care professionals having various qualifications and resources. I'm presenting the case of a 49-year-old male from Vaishali, Bihar, laborer by profession, who presented to a rural eye clinic with complaints of diminution of vision in the left eye. He was referred to the tertiary hospital with right eye disc edema. So he complained with of gradual painless diminution of vision in the left eye for the past 7 years, associated with frequent headaches. He recently experienced transient visual disturbances, and it was associated with worsening of the leg paresthesias for 10 months. There was history of occasional generalized body pains, improving on rest. He was investigated elsewhere a long time ago for these leg pains. There was no documented treatment history. At the present visit, his visual acuity in the right eye was 612 parts, and in the left eye it was finger counting at 1 meter. In the left eye, the fixation was poor and eccentric. There was RAPD. The right eye showed disc edema, and the left eye showed disc pallor. So a diagnosis of Foster-Kennedy syndrome was made, and it is strongly suspicious for intracranial mass lesion. As we all know, the differential diagnosis is the pseudo Foster-Kennedy syndrome. However, currently RKS ticks all the boxes for the Foster-Kennedy syndrome. So we requested for investigations, including color vision, contrast in undilated pupil, Humphrey field examination, and contrast enhanced MRI of the brain and orbits. And the patient was recalled with all the previous reports and advised to take a neurosurgeon's opinion. In the previous MRI, this was the finding that was striking. There was a mass lesion in the lower spinal cord at the D11-12 region, and neurogenic tumors was mentioned as the possible diagnosis. What was interesting was the previous AI-based retina screening, which says there was no signs of diabetic retinopathy or age-related macular degeneration, and the patient has to be re-examined after 12 months. Although there was eccentric fixation in the affected eye, this was the report for the retina screening. And regarding the disc, the algorithm has ignored the cup disc ratio difference. And although it is detecting the full cup currently, it has again mentioned this as no referable glaucoma, re-examine after 12 months.
So the provisional diagnosis was spinal cord tumor, very neurogenic, suspected frontal lobe secondary, causing Foster Kennedy syndrome. Regarding the further course of action, we discovered there was delayed referral following suggested screening interval by the AI algorithm. So we went on to read the fine print on the AI generated report. We went to review the approval documentation for the concerned algorithms. We tried to report this as an adverse event to the manufacturer, and we are going to report this as an adverse event to Material Vigilance Program of India, that is CDSCO. So CDSCO considers software as a medical device, that is SAMD, utilizing the AI for diagnosis, is a class C moderate to high risk device. The approval follows the necessary rules, and these devices are being marketed for about a decade as revolutionary advancements in the field of retinal screening. Let us read the fine print. So images are marked as insufficient in quality, yet the verdict is given regarding the condition of the retina. The physician assist software is mentioned, but the distribution of the device is not limited to physicians alone. The report does not screen for other conditions, but mentions a follow-up interval with complete disregard to this caveat. The cup risk ratio difference is ignored even when image quality is sufficient for assessment. And again, the cup risk ratio of more than 0.2 is found. It is suspicious for glaucomatous change. Algorithm does not consider it. So review of the regulatory approval documents of this particular device and the software reveal no mention of any approval to generate automated suggestion of the follow-up interval for any case screened. So FOP is approved as a camera, and the software is approved for the automated detection of the referable conditions. So potential use of the device or algorithm by less trained individuals may have life-threatening consequences. In conclusion, AI-based algorithms and devices, whether CDSCO approved or supported by 50+ publications, are not without pitfalls. The hype regarding the AI-based medical devices is uncalled for, and the consideration for practical implications must precede promotion and profiteering in the health tech industry. AI-based categorization of fundus photos as normal or abnormal may be a better approach in this regard. Thank you so much.
Thank you, Dr. Prateek. It's a nice presentation on AI and its implication, how much we should rely on it. So I guess Dr. Rajesh Joshi, are you there? Yeah, sure. So it's your next topic. So on AI, would you like to add?
No, I don't have anything to add. I could just say that it's just like those ECG, automated ECG reports. You read the waves, you don't read whatever is written on the ECG reports. It's just like that only.
I want to ask, in such a case, if the patient wants to go to court, who will be sued, the company or the doctor?
So very important point raised. There is a fine print written there for a reason, and a blank space is provided for the doctor's signature on the AI report as well. So yes, it is marketed as a physician assist service, but the marketing is not limited to physicians alone. So opticians, optometrists, and everyone can purchase the device and start screening on themselves. Once the device is commercially available, they are not looking at who is buying that device.
The vicarious responsibility finally will fall on the
Yes,
doctor.
finally it lies on the doctor, yes. If you, the ophthalmic physician community is using it, responsibility for everything lies on the ophthalmologist itself.
Yeah, actually the doctor who is signing it, I think it falls, but if we see it in a broad way, actually when these AIs create data, it is from the clinicians that they get data. So I think if that is proper filtering is not done at the base level, the centers which are giving these data, that does create impact creating the AI which is deficient in a way or so. So I think they have to have a role in it to take responsibility of it, isn't it?
No, but we are really not looking at who is creating this, the fundus using
at the end point.
At the end point.
I totally agree.
Yes.
Thank you.
Thank you.
Thank you. Thank you, Dr. Prateek. So Dr. Rajesh Joshi is going to present choosing the right IOL for diabetic eye. I'll request Dr. Neeraj Dr. Neeraj is our prominent retina surgeon, so he will be giving his view after this presentation, his point on choosing the right IOL for diabetic eyes. Sir, please, you start.
Thank you. I will be talking to you about choosing the right IOL for the diabetic eye, which is a topic of interest to all the cataract surgeon and the most debatable one. Nothing to disclose. Diabetic affects all ocular tissues, especially retina, and cataract occurs earlier and faster in diabetics. IOL choice influences the visual acuity, postoperative inflammation, and the long-term outcomes in these eyes. And as you know, the Phaco emulsification is the choice of method for cataract surgery. And the main aim for cataract surgery in this patient is to clear the media so that visualization of the retina and the treatment of retinal problems is possible. It's a clear corneal incision, mostly preferred, and the capsular axis of around 5 to 5.5 mm, well-centered axis ensures that the good optic overlap so that the PCO prevention is there, and tilt of IOL is also avoided, and better centration for future retinal imaging, so you should have a capsular axis of around 5.5 mm. And the chop technique, which is preferred by most of the surgeons, and thorough cortical cleanup is absolutely essential for the problems, which may develop postoperatively. The key considerations in diabetic patients are the glycemic control, which is absolutely essential, presence and severity of the diabetic retinopathy, which influences the visual outcome postoperatively. Macular status should be assessed preoperatively only. If you can visualize the retina by OCT, it's always better to do. If it is not possible, you note down the fundus findings, and you should note the previous retinal lasers and the intravitreal injections which patient has undergone for the diabetic retinopathy or diabetic macular edema, and the risk for future vitrectomy should also be assessed in these cases before implanting the choice of IOL. And these patients, they have pupillary dilatation which is poor, and there could be zonal adhesions, so these things should be taken care of while performing the cataract surgery in these eyes. Now, why IOL choice matters in these eyes? Because diabetic eyes have higher postoperative inflammation, there is a greater risk of posterior capsular opacification in these eyes, higher incidence of macular edema postoperatively, and future need for retinal imaging or vitrectomy. So IOL must provide stability, clarity, and diagnostic ease while performing imaging in these cases, and you should prefer square edge IOL because it prevents posterior capsular opacification. The best IOL recommendation is monofocal IOL because of its various advantages like excellent contrast sensitivity, best quality of retinal images, no dysphotopsias, most suitable when macular status is uncertain in these eyes, allows easy retinal treatment later on, and they are affordable and reliable as well. Most preferred material is hydrophobic acrylic because of less posterior capsular opacification, lower inflammation postoperatively, better long-term clarity in these eyes, and good biocompatibility. When not to use premium IOLs, any level of diabetic macular edema, moderate to severe non-proliferative diabetic retinopathy or proliferative diabetic retinopathy, in patients who have undergone retinal lasers or who have received anti-VEGFs, suspected macular ischemia, patients may need future vitrectomy. We should avoid premium IOLs in these eyes. And whenever patient has got poor contrast sensitivity and patients with irregular pupil or zonal weakness, we should avoid premium IOLs. Now, EDOP lenses, they can be used, but they should be used with caution, and they may be considered only if patient has no diabetic retinopathy, there is no macular diseases, excellent glycemic control, and patient understands the limitation of these IOLs. And patients, they are able to follow up post-operatively. Multifocal IOLs, why they should be used cautiously? Because they otherwise reduce contrast sensitivity, which is compromised in these eyes. There are increased chances of glare and halos with multifocal IOLs. Retinal pathology, there is poor visualization, particularly with those rings artifacts, difficult retinal evaluation due to rings artifacts, and the compliance, complicated vitrectomy visualization. But in fact, I am not a proper anterior segment surgeon to tell about all these things. Posterior segment surgeons, they can very well comment on this. Toric IOL in diabetics, they should be used if the macula is healthy, no significant diabetic retinopathy, and they are patients, if they are reliable to follow up, then you can use them. So these are all take-home points from my presentation, and thanks for your patience listening, and this is last appeal. Thank you.
Thank you, sir. So we have our posterior segment surgeon, Dr. Neeraj, to give some light. In the meantime, Dr. Nagendra Prasad is supposed to go a little bit early, so his topic we are going to pick up a bit early. So can optical biometer data be used for safety of phacoemulsification? Sir, in the meantime.
Yeah. One thing I'd like to add, please avoid yellow lenses. All the yellow lenses, there is very difficulty in doing PRP in those cases. Avoid multifocal lenses that he has told. And EDOF lenses are good, but if there is decentration, this is problem in that. Capsular axis should be 5.5 and 5.26 is a good thing. Before doing cataract surgery, as you said, always take the history of intravitreal injection. How many injections they have taken, and sometimes what happens, while giving intravitreal injection, there is PC touch. To make sure that you have, there is no PC tear or PC rupture, or there is no focal cataract somewhere. If there is focal cataract, cortical cataract somewhere in the periphery, that means it must there is lens touch before. And most of the diabetic patient with PDR, they get PRP done. PRP, it may lead to iris atrophy also, iris atrophy. Because of that, this pure pupillary dilatation is poor. So we have to take care of that also.
Thank you. Thank you for the inputs. So please.
Thanks, JHOS, for giving me this opportunity. It is coming to Jharkhand is always a homecoming to me, because I graduated from the RIMS already in this institute. My topic is, can optical biometer data add to the safety of the phacoemulsification? There are safety concerns in phacoemulsification. What are those? The capsular axis, it should be perfect and adequate size, because it's matter. It should be perfectly centered in the bag, in the capsule, and you have to have minimum endothelial damage during the phacoemulsification surgery, and you want always a easy nucleotomy. And protection of posterior capsule is utmost important. That could be disastrous, particularly if a nucleus drop occurs. Surgical success of a case depends upon mainly on these cases. So I am talking about the optical biometer. I have both the optical biometers, 500, IOL Master 500 and 700, but 700 gives this data. Not all the data provided by 500. So these are data obtained from the keratometer. So biometer is keratometry, anterior chamber depth, length thickness, axial length, central cornea thickness, wide to wide, diameter, pupil size, eye X and IY coordinate, angle kappa, and even you can have a foveal scan on this printout. So these are the three data which can, if you see those data and utilize, then it can add definitely to the safety of your phacoemulsification, like keratometry, anterior chamber depth and lens thickness. Keratometry and anterior chamber depth, though they are two separate measurements, but they are often related because they are both influenced by size and shape of the eye overall. You can expect larger deep anterior chamber in larger K values and accelerated anterior chamber in smaller K values, but this relationship is not true all the time, and it is related to the axial length too. Like Halliday identified the 9 types of eye, and you can have even if you have a short eye, you can have 80% chance of normal anterior chamber depth. Even in a long eye, you have 80%, 90% chance of normal anterior chamber. And in a short eye, you can have 20% chance of having small anterior chamber. So doing phacoemulsification in small chamber is definitely a difficult proposition. So once you know the depth of the anterior chamber beforehand, you can plan your surgery. What could be the problem arise during the phacoemulsification in the crowded AC? Your instrument maneuverability is very much restricted because you have very less cornea anterior chamber available for focusing and doing the maneuver. Increase the risk touching the surrounding structure. Fluid management, because AC is very small, it holds very little fluid, so AC fluctuation would be there in short crowded anterior chamber, and there may be post-occlusions also because of the same reason, and it could be dangerous, and it will lead to iris prolapse even in PCR. Visual disturbances, because you are most of the surgeon placing the corneal incision, and if you place, even if in slightly anterior, there is a corneal fold while doing the phacoemulsification. So you will have a very annoying visibility of the anterior chamber. Increased risk of endothelial damage because your phaco tip instrument and nuclear fragment are more close to the endothelium. Even in CCT, you are making CCT, there is capsular axis, there may be difficulties because what happens in a small eye, some zonules are definitely more anterior on the anterior capsule. And once you have raising your flap and making, and this anterior capsule flap entangles with the zonule, you have to do nucleotomy, or you can even have runoff, so compromising the safety of the phacoemulsification surgery. So how to avoid this? So if you look these parameters, you can place anterior chamber lamps, so there is a less chance of iris prolapse because there is always some hooding behind your tip. So this prevents the anterior chamber. Iris prolapse and into the anterior chamber. Iris prolapse into the wound. Sorry. And you make a short tunnel length. Ideally, it should be a square, but here you can have a slightly rectangle. So minimizing the corneal fold and more visibility. Use dispersive cohesive viscoelastics to protect the endothelium. Always use reduced flow rate and vacuum. Use iris retractor and stabilizer if you have a small iris, and or you do, some surgeons try to do peripheral arectomy or oral carbonic anhydrase inhibitor glycerometer before the before surgery. Again, there is a deep anterior chamber. Slightly little, 1 more minute, please. Increased working distance limits the visibility, depth perception, and making chopping the sculpting more challenging due to the longer fulcrum effect. Fluidics and chamber instability holds, because it holds a large volume of the fluid, so leads to the less stable fluidics, increase the turbulence, lens chattering into the anterior chamber. Tackling nucleus and fallibility is difficult because nucleus piece rotates because of the large anterior chamber. And positioning the tip, you have to have, if you are very deep, then you have to have position the tip vertically, so it is very difficult to do phaco in those cases. So adjust the bottle height and intraocular pressure accordingly. Lower fluid and vacuum and OVD, of course you can use OVD. Lens thickness and pyrometer, these are things which could not see most of the, overlooked by the many of the surgeons. Biometric measurement of natural lens thickness can be used to estimate the safe group depth during grooving. Technique like divide and conquer or stop and chop technique in phacoemulsification. Knowing the lens thickness help us to avoid inadvertently breaking the posterior capsule. Even if you are doing the direct chops, it helps in achieving impaling the proper depth for the phaco chop. Length thickness measurement also helps in how much depth to go toward periphery of the lens without going close to the posterior capsule, owing to the convex shape of the lens, where periphery is less closer to the tip from the central part. It also gives an idea of how big is the capsular bag to perform nucleotomy and conjunction of nucleus piece within bag away from the PC endothelium. So you have to look these factors also before going for the surgery. Here you can see here, this is the data. You can see here there is 33 mm almost anterior chamber length, and here anterior chamber depth is very short despite corneal normal keratometry value. So you expect not, and IR power you can see is -2. So expect difficulty in those cases despite the long axial length. Again, here you can see there is a small anterior chamber, and yes, just a small anterior chamber and a small anterior chamber doing Phaco in those cases difficult. So a little slight, just I am putting just placing the incision, little video. So you place your incision slightly anterior in the anterior corneal side, so you can have a safe phacoemulsification in those cases. So in conclusion, by observing the biometric data, you can expect the difficulty while going for phacoemulsification. Hence, a slight change in technique may add to the safety of the surgery. Like if you know the difficulty before surgery, you can plan better way to tackle the situation. Thanks for your patience hearing. Any question?
Thank you, Dr. Nagendra. So next is Dr. Seema. So it's a topic on cornea. So may I request Dr. Sunil sir? Dr. Sunil sir, it's a topic on cornea. So will you please like to give your inputs after the presentation?
Thank you.
Yeah.
Just one thing, Nagendra sir. In IL Master 700, we do get an image also of the posterior capsule. So in case of there is any rent or anything, is that we can make out?
Make out, definitely. I have presented a case or series of cases while there is a breach in the posterior capsule. You can imagine on the IL Master 700.
Yes, yes.
So this is very good information.
That's also very big help in case of posterior polar or posterior subcapsular cut.
Okay, nice. Thank you.
So one more thing I would like to add, that in these cases, especially if we have retinal cases, they take the optical biometer, it takes the axial length right from the RP. So that difference always makes a difference. I'll have a presentation regarding it, but there the refractive surprise decreases because immersion it takes from the ILM and the optical it takes from RP. Though it is less, but in many cases of macular edema, it does make difference in biometry. Thank you, sir.
A very good afternoon to one and all. I'll be presenting on large diameter anterior lamellar keratoplasty with in situ allogenic limbal stem cells in the management of chemical ocular trauma, a novel surgical technique. So I have no financial interests. As you all know, a little bit about the introduction. Chemical ocular burns, they are true ocular emergencies and they cause widespread damage to the corneal surface and the limbal stem cell naic. So one innovative solution to this is the combined large diameter anterior lamellar keratoplasty with in situ allogenic limbal stem cell transplantation. So a little bit about the pathophysiology in the clinical spectrum. These chemical agents, they disrupt the corneal epithelium, stroma and the limbal vasculature. So it has a lot of phases like in immediate phase, acute phase, repair phase, and in chronic phase you see that in spite of the attempted healing, there is persistent corneal epithelial defects, neovascularization and progressive scarring. A lot of complications of chemical injury can be encountered like chronic ocular surface, limbal stem cell deficiency, dry eyes, symblepharon formation, fornical shortening, very reduced visual acuity, lid abnormalities, exposure keratopathy, and a poor prognosis because of the persistent epithelial defects and the pain. So limbal ischemia is a very important predictor of healing process, and the extent of limbal ischemia will actually predict the poor healing. So a number of surgical adjuncts are there for this limbal ischemia. One of them is the AMT, that is the amniotic membrane transplantation, the keratolimbal grafting, and SLED. But over here, in severe chemical injuries, it's very urgent, there is an urgent need for the surgical solutions that simultaneously restore the ocular surface integrity as well as the visual function in these challenging cases. So if you compare the conventional methods to this method is a single step procedure which will lead to the replenishment of limbal stem cells, and it will give a early visual rehabilitation to avoid amblyopia, And it helps in removing the corneal scarring, provides a very early tectonic support, and does not preclude a future penetrating keratoplasty. So in the surgical technique, few important things are there, that we need to remove the symblepharon nicely, and then partial thickness trephine, and the size will be about 10.5 to 11 mm. And a manual layer by layer dissection over here is very mandatory, because we need to remove the scarring. And then in the donor side, we have to incorporate at least the size must be 1.5 mm larger than the donor cornea, and because it has to include the limbal stem cells also. And then you do the suturing, that is with with interrupted sutures. So you can see these post-op results at 1 day, and at 6 months, and at 9 months, and you can appreciate the corneal clarity that has been achieved. So there are two aspects to this. One is the large diameter anterior lamellar keratoplasty. So because the large diameter gives a very superior safety profile, because it helps in selective tissue replacement as compared to the penetrating keratoplasty. It offers, DALC offers lower endothelial rejection rates, a better globe integrity, and reduced risk of endophthalmitis. And the diameter of the graft should be greater than 9 mm, and it adequately caters to the peripheral scarring that has occurred. But yes, there are several challenges to this, because it lies in the technical difficulty. Then there are risk of descent membrane perforation during the conversion. That leads to the conversion. The other aspect is understanding the limbal stem cell deficiency after the chemical injury. So limbal stem cells, which are located in the vogut of palisads, and they are in the basal epithelium. So, and they express the markers like P63 and ABCG. So on impression cytology, if you lack the, if there is presence of cytokeratin 3, then it means that conjunctivalization of the cornea has occurred. So these are the long-term results you can appreciate with respect to penetrating keratoplasty. The visual acuity is good, and the recent studies by Rasik Vajpayee, they have also they have shown that large diameter anterior lamellar keratoplasty is a very useful therapeutic modality in cases of severe alkali burns. These are similar pictures, and they hold a similar opinion. And if you look at the evidence-based studies, 78% of corneal clarity is maintained at 2-year follow-up, and 2.5 average lines can be gained on Snellen vision chart. 15% incidences of stromal rejection episodes, which can be easily catered and are responsive to treatment, and 85% are able to achieve the stable ocular surface without persistent epithelial defects. And with the complications are there, like interface haze and scarring, you can see persistent epithelial defects can occur, stromal rejection rates and recurrent limbal deficiency can also occur. So the take-home message is that this is a viable option. It plays a very important role in severe chemical burns, which are associated with corneal thinning, and a simultaneous stem cell transplantation and visual rehabilitation can be gained in one go, and it is a useful adjunct in bilateral burns. Thank you.
Thank you, ma'am. I request Dr. Sunil sir to share his experience with chemical injury and limbal stem cell deficiency, and its how much failure rate in his experience. In the meantime, Dr. Archana, please get ready. So Dr. Sunil, please your experience.
I missed the presentation of Dr. Seema, but the SLET is very good option and very simple method. I think it only needs even the other eye is normal, the other eye we can take the limbal graft, and we just need the fibrin glue amniotic membrane, and the results are wonderful, really wonderful. So I think it is a good options. Any question, then I can.
Thank you, sir.
Yeah, it's actually your experience in chemical injury management.
Yeah, I have done few SLET in the late period, but most important thing is the earliest management. Whenever the patient comes with a chemical injury, what immediate management we do, that decides what is the future of the patient. And Immediate, if the patient comes immediately, the immediate, as we all know, the VAS, complete is VAS of the patient is important. Another important thing is there to give the steroids. Sometimes what happens is, if the patient comes and we see the epithelial defect and everyone is hesitant to give the steroids. But first 10 days the steroid is must, even if it is total epithelial defect, we should give the steroid, that is the prednisolone, and that too in high dose. Minimum 8 to 10 times must be given oral visolone, and the other thing is the supportive treatment is important.
Thank you, sir. Thank you for sharing. Dr. Archana, please.
Good afternoon, everybody. I see most of the people are having food. It is time for lunch. It will be difficult to digest this topic, I think, so I'll try to make it a bit interesting. So today I'm planning, let's navigate the challenges of cataract surgery in vitrectomized eye. So first of all, everyone in the house who are doing phaco surgery, how many of us have actually seen a refractive surprise with post-vitrectomized eye? Or not seen actually, that is also a big deal. B.N. Gupta sir, not seen. Ajay Gupta sir, that's really, sir, panel mein. Sir, any refractive surprise in retinal diseases, silicone oil, eyes, post-cataract surgery?
What's the question, please? Will you please repeat, mind repeating?
Sure.
Yeah, please.
You were busy. So, in post-vitrectomized eye, doing cataract surgery, how commonly do we see refractive surprise?
We do see, but
have you seen in your
yes,
practice?
yes, absolutely.
So that
not be used, but yes.
Yeah.
Yes.
So there we are. We have actually do have refractive surprise. Sir, please.
So surprise is something which you are not expecting. So in these cases you already expect that you are not going to reach your emetropic target bang on. So you have already explained to the patient.
Sir, I was expecting this answer. Thank you. Actually, in one of the presentation I was doing in the national conference, and one of my colleagues said कि retinal disease में दिख रहा है बहुत है, हम बहुत चिंता नहीं करते emetropia की. So, but actually, sir, many times it is after a good retinal surgery or per se, this is, especially if oil is there, tamponates are there, it is very difficult to come, and the process of cataract surgery is also different. So, I wanted to talk on this today. So, to introduce why this topic, because cataract surgery is as common as 80% after post-vitrectomy in eyes, and this occurs within 2 years. It is the most common complication of vitrectomy actually. So these patients have high visual demands, especially after good retinal surgery, when they had a pre-op good vision, post-op good vision after retinal surgery. And refractive surprise is common because these patients post-vitrectomy has anatomical as well as refractive variables induced, and most of the formulas that we have are for virgin eyes, not for vitrectomized eyes. So the altered biometry, why is it so? Because of, first of all, the axial length, either because of pre-existing retinal condition like staphylomas or retinal detachment, or if we have tamponades there, or it was even if used in the past, and keratometry. They do even change in cases like where do buckling or multiple vitrectomies. So the intra-op challenge, the first intra-op challenge that will be faced is usually deep chamber phenomenon. There is lens iris diaphragm retraction syndrome, and that happens in as high as 83% of the eyes post-vitrectomy. So these eyes have actually a reverse pupillary block where the iris adheres to the lens, causing extreme deepening of the AC. So fluctuating myopia is very common because the iris lens diaphragm is moving very easily. And the solution is very easy, just to lift the edge of the iris, and then we get a plane where viscoelastic can be introduced. Intra-op challenge 2 is capsulorhexis. If the deep AC is deep, it is difficult, and many times the effective position of the crystalline lens also keep changing. Hydrodissection dangerous because many of these patients may already have blowout syndrome, like can happen in these cases because they may have a PC defect either during trocar entry or because of PC defect that happen because of lens touch during vitrectomy. So it is preferable to do hydrodelineation in these cases, otherwise during hydrodissection also lens drop chances are there. Now, challenge 3 is that definitely when the phaco starts, the dynamics should be kept slow. There is a trampoline effect which is very commonly seen here, and this is because of the high mobility of the lens iris diaphragm, so there can be sudden surge and sudden deepening. The management is again to go for phaco chop straight away so that there is no stress to the zonules, and mind that these patients many times have subclinical zonule deficiency which cannot be seen pre-op. And that again can be because of trocar entry or maneuvering during the retinal surgery. So slow motion phaco is advised. Now for the silicone oil filled eye, there is all different set of challenge. If we are doing the surgery in eye which already has silicone oil, the visualization of PC is hazy. There is an optical illusion, refractive index difference. And next is buoyancy issues. The oil will keep pushing the PC up. So the IOL calculation in vitrectomized eye, the main inaccuracies are axial length measurement that we have discussed, especially with an eye which is tamponade because of the slow speed of the sound. In the silicone oil, what we see is that the axial length appears longer. Similarly, for gas, it is difficult to get an axial length. Effective lens position is more posterior. Optical biometer, no doubt, is gold standard. But again, the formulas are something that we have to keep in mind. So for standard post-PPV eyes, Kane's formula is the standard. Barrett Universal 2 is the winner in all the cases. But for long axial length, again, we should go with Holiday 2, more like conventional. Scleral buckle, we have to be very, apart from the axial length lengthening, there is change in keratometry. Now the biometry channel, like as retinal surgeon usually, or for any setup, we usually do a biometry for all the cases which are to be taken up for surgery, retinal surgery, in case we need it on table. So in these cases, A scan, we have to be very careful, especially in macula of RD, that the posterior peak should be taken into consideration rather than the anterior peak. And scleral buckle, we have already covered. The axial length is increased, keratometry changes can be there. IOL calculation in silicone filled, oil filled eye, especially if we don't have optical biometer, there are a few corrections that can be kept in mind, like a factor of 0.71 being multiplied with the axial length measurement done with normal speed of the sound in the eye. And if we get very precise, we can actually divide it length of axial length plus lens thickness and 0.64 multiplied to vitreous cavity length. These patients do have refractive surprise, and risk is very high in spite of all the care that we take, because the refractive index is different in these patients, and the posterior power loss is there. Many times in eyes, especially eyes which are to keep oil for long or maybe for life, the IOL and the silicone oil nullifies the posterior lens power. So in that case, it is advisable to put an implant which is meniscus lens or convex plano IOL. So rule of the thumb in these cases is to add IOL power by +3 or +6 diopter. IOL calculation specifically should be done in sitting position in these cases, because there is always a retrosilicon space which will change the refractive index and the axial length measurement will be wrong. So IOL power calculation, if not, can be taken with the fellow eye if we are sure, but this has limitations, like it cannot be done in anisometropic eyes, which are mostly the cause of unilateral retinal detachments, or in one-eyed patients. And pre-vitrectomy axial length can be taken into consideration if it was not a macula of RD, and definitely optical biometer is the winner. 10 times more accuracy is seen. So the golden rule is keep your bottle height slow, gentle hydro should be done. Expect the unexpected, keep a 3-piece IOL in hand and a vitrectomy setup if at all, and counsel, because refractive surprises can be there anytime. Thank you.
Thank you, Dr. Archana. In the meantime, I'll request discussants to give their comments, and I'll be ready for my own presentation on Eisenhower Matrix. It's actually it's there, already uploaded. Yeah. Yes. So it's related to management that we have to go through during like our MBA. So I'll request Dr. Jharkhand sir to give, because you are somebody who is versatile, who always, do this all priority setting is a part of your lifestyle that we all understand. So this is how, where always we used to be in a code blue, but it's because there is a lack of awareness in understanding the priority. So the first thing is that we must understand what are the challenges in managing the time and which things are actually important and which are under the urgent. So once we identify those things, then we have to go for the quadrant. So these are the 4 quadrants. So how quickly it's under the spinal reflex that quickly we can manage your time. So let's say like right now we are, it's time for lunch, so it's important but not urgent. And if I'll not close the meeting very soon, then it will be important and urgent. So we all have to run. So it's kind of, procrastination. So if you will be procrastinating the things, it will go from important, not urgent, to important and urgent. And if you are staying in a lot of time in important and urgent throughout your time, 80% of the time, that means how much adrenaline surge you are going through. So if you are somebody who believes in excellence, then most of your work has to happen when it is important but not urgent. Like a child studying every day, it's not urgent, but before exam, it's important and urgent. So come to the next, quadrant. So there are few things which are urgent, but not important. So any example, Dr. Archana, you would like to give the things that you feel it's urgent, but not important?
For me, it is very urgent. Am I audible? Yeah. For me, it is very urgent if I get a nucleus drop and the patient is very aggressive.
But it is not important, because my question is,
surgeon out there.
My question is, it's urgent but not important. It's urgent but not important.
For me, it is actually urgent,
but not important. Is that so? There are work which is urgent but not important.
It depends on, how much trouble in my anterior segment surgeon is. Sir?
Any of your daily life also you can explain. You can give one example that you feel it's urgent but not important. Dr. Shruti, please. Yeah.
Taking a call from my dean when I'm doing an OPD. It is urgent but may not be always.
Oh wow, great. So that's absolutely, so you can delegate. That means you can delegate that to somebody. So it's the reflex how quickly you can divide your work, and that is also something remain, it's not important, not urgent. So it's actually you should be removing from your professional career but not from personal. Just like going for movie, it's not important, not urgent, but has to be there in the life. If you don't have, your life is suffering. So it's all depends on how quickly you have the awareness and how are you prioritizing and how are you actually implementing this knowledge. So this is the key takeaways for this, and this is what we hope so. Next time when opportunity calls you, you are in the right position to take it up. So thank you. Dr. Jharkhand sir, would you like to comment? And the next and last speaker, Dr. Priya.
Yeah, this is one of the good management tool you can utilize anywhere when you are trying to prioritize your thing. So here you know what are the things prioritized. Lunch is always there. So you can plan whether it's urgent or important. And we are still continuing because I'm here. It's very important for me and I have to be here. So this is also one of the examples. So you have to prioritize according to the situation and time. That's okay.
Thank you, sir. So, Dr. Priya, this is the last talk for this session.
Good afternoon, everyone, all the delegates present here, myself, Dr. Priya. So, after all the wonderful yet heavy discussions, let us all get something into light-hearted and dive into solving an unsolved myth, which is association of intraocular pressure with central serous chorioretinopathy. So as we all know, CSCR involves fluid leakage from choroid into the subretinal space, leading to serous detachment of the retinal pigment epithelium. The possible causes of it are choroidal vascular hyperpermeability, which is basically due to the Holler's layer, the outer layer of choroid, which contains large-sized vessels, which becomes dilated, congested, and leaky. Then we have pachychoroid, where the thickness of choroid is more than 300 to 350 microns of foveally, and dilated vessels leads to CSCR. Then we have steroid-induced CSCR by activating the mineralocorticoid receptors present on choroidal endothelial cells and RPE. Sympathetic dysregulation in cases of type A personalities with high stress levels leading to release of cortisol and catecholamines affecting the choroidal circulatory balance leading to CSCR. So now we come to our topic of major interest, which is intraocular pressure, which basically acts as a two-edged sword. So what do I actually mean by two-edged sword? It can act by both ways, low intraocular pressure and high intraocular pressure. Low intraocular pressure is related through its negative contribution to ocular perfusion pressure. Mean ocular perfusion pressure is given by 2/3 of mean arterial pressure minus the intraocular pressure. High intraocular pressure in cases of steroid excess through activation of mineralocorticoid receptors in choroidal vessels, causing increased vascular permeability, and through lowering the ocular perfusion pressure according to the formula given above. So excuse me. Pathophysiology in low IOP. Can I get some water? Excuse me. So pathophysiology in case of low IOP, as IOP decreases, choroidal perfusion increases, which creates increased hydrostatic pressure gradient between the two sides of RPE, movement of fluid into subretinal space and serous retinal detachment. Also, low IOP results in lower hydrostatic pressure in the subretinal space. So basically what works here is physics vector model. Like the low IOP, which acts from the vitreous side, from inside, gets overwhelmed by the mean arterial pressure and mean ocular perfusion pressure, which acts from outside, and this results into CSCR. Therapeutic implications: understanding the physics behind IOP acting over here opens avenues for new treatment strategies, like modifying pressure dynamics through modulating the steroid effect, sympathetic overdrive, and blood pressure, using medications that affect IOP like mineralocorticoid receptor antagonists like spironolactone and eplerenone, carbonic anhydrase inhibitors, acetazolamide, dorzolamide. Mostly prostaglandins are avoided in these cases as far as possible because they lead to increased choroidal vascular permeability. Then influencing choroidal venous outflow by reducing the episcleral venous pressure. Then there are conditions in which we actually have hypotonous maculopathy, but it mimics CSCR. Such conditions occur in cases of low IOP less than 6 millimeters of mercury. Now, evidence-based studies show association of intraocular pressure with CSCR guidelines. The association is significant. IOP is a strong predictor of the disease. Studies have shown that patients with CSCR have lower IOP values compared to healthy controls, indicating a potential role of IOP in the pathogenesis of the disease. The study published in the American Journal of Ophthalmology revealed that IOP was the strongest disease predictor, with an area under the curve of 0.9, significantly superior to mean ocular perfusion pressure and anterior scleral thickness. This suggests that IOP should be considered in the guidelines for CSCR diagnosis and management. So my clinical observation in few CSCR patients in OPD was 65% of patients had IOP between 10 to 14 millimeters of mercury. 20% patients had steroid-induced acute CSCR with IOP between 18 to 24 millimeters. 15% patients had chronic recurrent CSCR with variable random IOP values. So management was decided according to the groups. Group 1 with low normal IOP was managed conservatively, considered an incidental association of low IOP with CSCR and not primarily pathogenic. Group 2 steroid-induced acute CSCR was managed with steroid withdrawal and carefully monitored use of IOP-lowering drugs. Group 3, the chronic recurrent CSCR was treated with MRAs. One patient showed improvement of 2 lines in visual acuity. So take-home message is, association is not always equal to causation. CSCR patients tend to be young and middle-aged, often non-glaucomatous, hence the association can be incidental. Treatment should be individualized based on etiology and not driven solely by IOP values. Thank you.
So thank you, Dr. Priya. I'll request Dr. Archana to put some light on this.
Hello. Yeah, Priya, very nice presentation.
Thank
I
you.
must say, you have done it in your private setup, it's your personal setup?
Ma'am, some I did in private setup, but right now I am working in Sadar Hospital, Ranchi. So there also I take pains in checking all these parameters for CSCR patients as far as possible.
Appreciable.
Thank you.
Very nice. One very important thing that actually I think the message is that you have already stated, that it is not always IOP which will, because sometimes it is other factor that we have to look to, but yeah, IOP is a very important consideration. I think lot of studies are going on this, and you have actually started it here. It's really a deal, because many people are actually talking, and many people, it has been considered in many states that IOP will be the modulating factor in future in CSCR correction.
Actually, ma'am, what I saw was that drugs like IOP lowering drugs and MRAs, they are used very randomly by doctors. So that actually made a catch, like actually we should first try to understand what actually is the pathophysiology. Should we go for over-aggressive treatment, or should there be some demarcation line where to stop and then like go ahead?
True, because these things again has been implicated in the treatment also. Like steroid is said to be a causative, while they, the eplerenone group, which are the antagonists, have been used in the treatment of chronic CSCR.
Yes, ma'am.
So this is something that is a very interesting and nice topic. I will suggest you to actually go long into it.
Thank you. Thank you so much, ma'am. Thank
for
you, ma'am.
presenting it.
Thank you, Dr. Priya. Thank you, Dr. Priya. Now we have completed all the sessions, so I'll request Dr. Bharti ma'am to come to the dais for the valedictory, and I'll also request Dr. Rahul Prasad, Dr. Pritish Pranay, please. Dr. Sunil sir, please.
बहुत अच्छा किया। सुनो ना, डॉक्टर रेनू मेहर, इनका नहीं हुआ है, बोला लेके आओ। So we are felicitating our chairperson, Dr. Renu Meher. सर आइए। एक फ्लावर भी ले आओ। फ्लावर यहीं रख दो पीछे से। डॉक्टर बीपी कश्यप सर को बुलाया जाए, चेयरमैन रिसेप्शन कमेटी। बीपी कश्यप सर को कॉल करिए तुरंत। फूल भी दे दो। हाँ यहीं बैठो. हाँ. Please call Dr. Kashyap. Please call Dr. D.P. Kashyap. हरीश का हुआ? हरीश का हो गया? क्या? Yes, Dr. Harish, you have to, we honor you for the JHOS excellence because you have contributed in public awareness. इधर आ जाइए घेरा में घुमाना है. जाइए सर के साथ जाइए, बीच में जाइए. ये नहीं था लेकिन आपको दिया जा रहा है, किसी को नहीं दिया है, आपको दे रहे हैं. लेकिन अगला बार आपकी किस टीम पे है. प्लीज क्लैप फॉर हिम. गुड. ये तुम्हारा एक्सीलेंस है, सॉरी ये तुम्हारा जॉस एक्सीलेंस. चेयरपर्सन वाला हो गया है. दे दो एक उठा के. तू अपना स्टिकर चेंज कर. ब्लैक वाला दे रहे हैं, स्टिकर बना देना. वो हो जाएगा, 2 मिनट में हो जाएगा. बैठे रहोगे तो अभी बना देंगे. सब बच्चा क्या करना है. राजकुमार को बुला, बोलो. राजकुमार को ये बच्चे की तो वीडियो में डॉक्टर बी.एन. गुप्ता सर, डॉक्टर सरोजनी, फोन करो ना, राहुल फोन करो ना सरोजनी को. प्लीज कॉल कश्यप सर. सरोजनी मुर्मू. किसी स्टाफ को भेजिए. राजकुमार. अरे फूल यहीं पर जाओ. ये लीडर है बहुत बड़ी, इसी का रजनी कुछ है. चलो अभी किसका है? हाँ डॉक्टर नीरज कुमार. सब दे रहे हैं सर. किया कुछ नहीं है, जानबूझ के दे रहे हैं.
दे रहे हैं.
हाँ अच्छा करना, राखी बनवाते हो. अच्छा लो. इसके बाद सब जो हम लोग का नियत बहुत अच्छा है.
डॉक्टर प्रिया अभी जो स्पीकर मैम, डॉक्टर प्रिया एंडी मिश्रा.
डॉक्टर प्रिया और डॉक्टर एंडी मिश्रा. डॉक्टर प्रिया, डॉक्टर एंडी मिश्रा. डॉक्टर बी.एन. गुप्ता सर. फोन करो ना, मेरा मोबाइल कहाँ है? ओम कंप्यूटर पर्सन ब्रिंग. बी.एन. गुप्ता सर आप आइए. नहीं फिर वो कहेंगे कि तुम लोग हम ये नहीं करते, वो नहीं करते. छोड़ दीजिए, दूसरे का नाम है. हाँ यही बोला थे. जो चीज किए थे वही ना देंगे. छोड़ दो, जो चीज किए थे. जल्दी आओ, बुलाओ. डॉक्टर एंडी मिश्रा यही ना. हाँ रुको. ये चेयरपर्सन बड़ा वाला भी देते हैं. रुकिए शॉल भी उड़ा देते हैं. लाओ 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 लाओ।
I think we have one more, Dr. Bharti.
Vote appeal.
Dr. Ravi Ranjan का देखिए, Dr. Ravi Ranjan.
हो गया।
कश्यप सर? डॉक्टर रवि रंजन बाकी है सामने देखिए सामने देखिए स्माइल थैंक यू डॉक्टर प्रिया पीछे से लो ना सामने से नहीं लो
पीछे से ले रहा है। अभी इसका रवि आप स्पीकर वाला मिला ही नहीं। नाम नहीं चलो ना Chairperson. Hello. So now we actually our felicitation of our office bearers and the JHOS LOC was supposed to be done like in any other societies. It happens during the time of inauguration. But as the minister was in hurry, we could not do it. So now we want to honor our chairperson reception committee, Dr. BP Kashyap. अरे सबका हो रहा है वही तो
राजीव कुमार सर का फेलिसिटेशन बाकी है
क्या
राजीव
क्या उसको तो दिन लाइफ टाइम अचीवमेंट तो मिल गया हम तो दे दिए तो दे दी तो पहले वाला दिए हो ना देखो स्पीकर का दो राजीव सर आइए सतराम सिंह सर उनका भी नहीं हुआ उनको भी दो आइए सतराम सिंह सर आइए आप भी आइए जाइए आप आइए
मेरा इसमें क्या रिलेशनशिप पता है ना
नहीं जाइए एक सर बड़ा वाला है वही तो है बहुत अच्छा से वही तो है किसका है वही है किसका है वही है हाँ हाँ बुलाइए वो तो सर आपको दूसरे का दे रहे हैं उसको करवा दीजिए पकड़िए ना और आपको हम वो वाला बड़ा वाला सर आप इतना लोग चेक साइन किए हैं चेक साइन किए हैं जाइए आपका दोस्त पुराना दोस्त ले लो तब फिर उनके घर से कौन लाएगा दे दीजिए कि मेरे घर भिजवाओ करवा के उनके घर से कौन लाएगा फिर
और कौन
ऑर्गेनाइजिंग सेक्रेटरी प्रीतिश प्रणॉय शॉल भी लाओ भाई
लाके
चेयरमैन रिसेप्शन कमेटी डॉक्टर बीपी कश्यप
यहाँ लाके दो जमा कर दो ना 4-5 तो उधर बार बार जाना पड़ रहा है यहाँ रख दो
सब
ले आओ ना यहाँ पे यहीं पे रख दो
राहुल का है हाँ सर यहीं पर आप जरा ये बगल में ना
तीनों को एक साथ कर दिया जाए नहीं ऐसे करते हैं तो बीच में करो
सर हम लोग ऐसे एकदम सही है सर हम लोग एकदम सही
सबको कर देते हैं सीक्वेंस में रुको हमें बहुत अच्छा फोटो खिंचा देते हैं रुको क्या सबको दो
लाइन से लगा दीजिए
मेन वर्कर्स ऑफ दिस कॉन्फ्रेंस नहीं मैम आप तो है ही मैम
आप तो हो सकते हैं
ये लो ना ट्रे में कर
लाओ सुनील का है सुनील का है
हाँ मैम
वंदना प्रसाद डॉली टंडन को फोन करो मलय वर्मा वंदना प्रसाद डॉली टंडन फोन करो अब मेरा भी दो शॉल कितना है ठीक है ना रुको हम करते हैं रुको
हाँ मैम अरे घर जा मैम आपका प्रेसिडेंट का
ओ हमरा पता नहीं चलो
एक वहाँ से लीजिए ये लीजिए पढ़
भारती कश्यप मलय वर्मा को फोन करो मलय वर्मा को फोन करो ये रहा मलय वर्मा को फोन करो किसका है मलय वर्मा को फोन करो
ये कुछ यूनिक हो
सबको ऐसे करो ना बहुत अच्छा ऐसे बगल में सर ऐसे करो द टीम मलय वर्मा को भिजवाएंगे
ये जो आप जो देख रहे हैं मोमेंटो जितना ना बहुत बहुत मुश्किल से प्राप्त हो
दीपक
मुरादाबाद से आया है
जर्नल
बहुत आइए
जल्दी आओ मेरा वाला
जनरल की बारी
पीछे क्या बैठे
राशि साहब को फोन करो ना कहाँ है अब नहीं है मतलब
आइए सर
सुनिए ना अभी हम सॉल्व को कुछ आइए
मलय बॉस
आइए सुनिए पकड़िए प्रेसिडेंट
आइए बॉस जॉस नहीं बॉस ऐसे तो नहीं आइए
हो गया फोटो खींचा
मलय बॉस आ गए
अरे इनका खींचो ना पहले इसको देना होगा ये अब बदला बदली होगा हमरा है हम
हाँ ठीक है मैम हम लोग यहीं पर बोले जाइए, बड़े बस आइए, बीच में आइए, बॉस आप रहिएगा।
आइए 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 मैडम। सुनो राशि का लेके जाओ, राशि का दो।
On this special occasion, I'll slightly divert deviate from.
Tinku ji, where are you?
Yeah, I want to little deviate from this, and then I want to call the caterer, the food which you had, the lovely food, our caterer, Tinku ji. Tinku ji, please come. और इनके नाम को ना बहुत बढ़िया से स्वर्णाक्षरों में लिखा जाए, that one person who helped all of us. आपने जो breakfast किया, जो lunch किया, जो dinner था, everything, it was arranged by him. And I don't think there was any flaw. It was a flawless. And everybody enjoyed the meals. आइए, all of us. टिंकू जी इसको फोटो को मढ़वा कर रखिएगा, ठीक है ना? हम लोग बढ़िया से फोटो खिंचवा रहे हैं, बढ़िया फोटो होना चाहिए। लिखिएगा हम लोग का कॉन्फ्रेंस के बारे में कि was appreciated for your work.
और कोई बचा?
Hello. To organize this conference and to make a success, the person who are working behind the scene should be applauded with two hands. सबके लिए cheers एक बार. उनमें से ये लोग बाहर में they are working very hard, they are not seen, but the invisible person, without them this conference would have been so successful. What I think is a successful and a good run conference. Very beginning, शुरू से बात करते हैं, मैडम के साथ जो अटैच रहती है, प्रेमलता, thank you for maintaining all the mementos, for all the certificates and all the registrations. इतना बार डांट, इतना बार negligence, सब माफ, cheers. आ जाओ. नेक्स्ट नितेश जितना भी हमारा वो वाला डेस्क संभाल रहा है, इज इंचार्ज ऑफ ऑल द वीडियोस, द लाइव स्ट्रीमिंग which was done in Facebook, in YouTube, and all the uploading of things, computers type of thing, gadgets are taken care by Nitesh. 3 cheers for Nitesh. Premlata, please come up to the stage. Nitesh, aa jao bhai. Next is our accommodation was taken care by Nitin. By profession, he is himself a hospital management person. तो उनको जिम्मेवारी देने के बाद, we as a organizing secretary didn't had a second thought कि हमको कोई problem हुआ हो, कि कोई भी management mismanage हुआ regarding all the faculties, guest faculties, then didn't had any problem regarding the services in the room and accommodations. Thank you, Nitin. Wherever you are, please come up to the stage. Ankur, next is Ankur. He's sitting there inside. Computers में है, मैडम जब बोल रही है अंकुर, where are you? दौड़ के आ जा रहा है. कहाँ पर अंकुर है, दौड़ के आ जा रहा है, किसको चाहिए अंकुर? अंकुर, थैंक यू वेरी मच, प्लीज कम अप टू द स्टेज. Next department was travel. Travel was taken care very precisely and very rightly by the Ajanta people. Agar koi Ajanta people hai, Rishu, wherever you are, please come up to the stage.
We have missed this quiz trophy. Quiz trophy, please come.
Ajanta, Rishu, if you are there, please come up to the stage. I'm boling last one. Next is Anand, वहाँ पर बैठा हुआ है. He has taken care of all the food coupons. कोई भी responsibility उसे दिया हुआ है, he has taken care of all the beverages. कोई भी इधर से miss नहीं किया, neither the bottles nor the food coupons wherever he are. Oh, he came to me, he was there was side for me. कभी भी जरूरत पड़ा, दोनों हाथ से काम किया. Anand, please come up to the stage.
Rajkumar.
And
Rajkumar.
दो और members, I think they are not here. One Rajnikant. Where is Rajnikant? Rajnikant, thank you very much. Another was Shamim. Shamim bhi hai, he was from Hazaribagh. His work also very flawless. जब भी मिला एक हाथ उठा करके काम किया. And his main work was that to bring the mementos from Delhi to Ranchi for him. I'm talking about Shamim. जिसके चलते उन्होंने बहुत से एफर्ट लगाया, बहुत पेन हुआ उसके लिए. वी आर वेरी थैंकफुल टू शमीम. एंड टू मैनेज एवरीथिंग, लास्ट वाज दैट पर्सन सिटिंग देयर. विदाउट राजकुमार ये पॉसिबल नहीं था. आ जाओ भाई. ये लड़का ऑलवेज देयर विद मैडम. मैडम का नाम प्लीज ओम आप कम टू स्टेज. शशि, अच्छा फोटो. विजय, please come up to the stage. Shashi, please come up to the stage. These all are the members from Kashyap Hospital. Ma'am, very thank you, sir. Very thank you for arranging this for us. Yeah, please. Sir, आप भी आ जाइए. Everyone, please, sir, please आ जाइए, sir. President, sir, please come up to the stage. Sunil, sir.
President, sir, quiz करा दीजिए, quiz करा दीजिए.
नीरज बॉस आ जाइए. Malay, sir.
They are all manager level people and they have really executed well.
Hello, sir, please come up to the stage.
Yeah.
नितेश तुम्हारा बीच का. जाओ तुम नेता के पास उधर.
Malay boss.
बहुत बड़ा. हाँ, हम कोटा में रहते हैं, कोई दिक्कत नहीं है. तुम कहाँ इधर आ गया? स्टाफ के बगल में, स्टाफ के बीच में रखो मैनेजर लोग को. सारा मैनेजर लोग में है. हाँ ठीक है. रिशु और वो दूसरा साहब. अच्छा ठीक है. नहीं तुम वहीं पर जाओ. तुम्हारा आइडेंटिटी खत्म हो गया.
ये पिक्चर को भी फ्रेम कर देना भाई, कोई मिस न करे नेक्स्ट कॉन्फ्रेंस के लिए.
यस, सब लोग को बोलो प्रॉमिस अभी कराएंगे.
This is going to the team for the All India Midterm Conference.
Yes.
It is coming in Ranchi.
यस. विजय कहाँ गया? विजय, अरे वो लड़का मेरा दीपक. स्वप्निल. इसके बाद वो भी आएगा. स्वप्निल. आशुतोष बैठा है. हम जानते थे तुम लोग कहाँ बैठे हो. लड़की के साथ रहता है. बैठा हुआ है. मतलब उन लोगों को अवार्ड से भी ज्यादा पसंद वही है. कब
सब आगे, आप लोग बीच में भी आगे बैठ सकते हो.
बैठ जाओ. तुम भी बैठ जाओ. छुट्टा
आप कुछ लोगों को बैठा दीजिए. गुड.
शशिकांत, तुम बैठ जाओ.
इधर आ जाइए.
इधर आ जाओ.
निधि आ जाओ. हमारी एलओसी है, छूट जा रही है. प्लीज. She organized everything. He managed all the. She managed प्रयोगशाला. Thank you, Nidhi, for doing the service. आ जाओ प्लीज.
तुम भी आगे ही बैठ जाओ दीदी. पूरे कोना में छिप जाओगी. नीचे बैठो. नहीं बीच में.
उसके साथ उसका पीछे में छिप जाएगा ना, वहीं पर.
डॉक्टर निधि Dr. Nidhi, come this side. Come this side. This side.
सर जोड़ी इसी के साथ है
Come this side. Come. You are आप एकदम sir. Yes. Are we good? हमारा भाई.
क्विज करा तो क्विज वाला तो बाप रे
3 cheers, hip hip, hip hip.
ए रुको 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 कोई मत जाना नितेश जाओ उसका भी हां हां बैठो वो आ जाए
दीपा भाई नितेश में जा रहे हैं आप आइए नितेश भाई
सुनो उसके बाद मत जाना ये क्विज वाला बच्चा लोग का क्विज वाला बच्चा लोग को भी सुनते रहो गगनदीप आओ जल्दी क्विज के बच्चे जल्दी आओ क्विज वाले बच्चे खड़े रहिए यहाँ पे रिम्स वाले बच्चे को भी लाइए कोई नहीं हिलना कोई नहीं हिलना क्विज का बच्चा छूट गया
अच्छा नहीं मैं इन लोग को जाने दीजिए इन लोग को जाने दीजिए
सब लोग बहुत
मैम द लास्ट ये लास्ट हम लोग कर जाते हैं क्विज वालों को ये कर
क्विज वाला को कर देते हैं
हम लोग हैं
हेलो हेलो हेलो
बच्चा लोग को क्या किया अपना जैसे पैसा जो दिया सर आओ चौल
क्विज के विनर का मैम अनाउंस करें
Gagandeep and आपका नाम क्या हुआ? Pragya are the winners of the quiz to 23rd Jhoscon. 3 cheers for Gagandeep and Pragya.
Gagandeep and Pragya, they have won the lottery also. Yeah. They have won a briefcase, suitcase and a hot air, क्या बोलते हैं उसको? Oven. Air fryer. May I request the trade people to come over to the dais? We want to have a photograph of you people. All the trade people, can we have you here on the stage?
I request Dr. Seema to come up to the stage to collect the runners of trophy for this quiz competition. For Amar. For Amar and? Amar and Mayank, the runners of quiz. We request all the trays to please come up to the stage.
May I request all the trade people to come to the dais? We want to have a picture of yours with us. Yeah, everybody. Somebody sitting, somebody, standing, somebody down, somebody up, so that everybody is accommodated. Thank you. Please come. And I must thank you people for having participated in our annual conference. It was not possible without your cooperation. Or Nobody from Appasamy, nobody else from Antod, NRI. Hey, to NRI.
Great delegates, please come up. मुर्गेश जी कहाँ हैं?
मेरी आवाज जहां तक पहुंच पा रही है, please all come. All the trade delegates, please come onto the dais. We want to have a picture with you. Please come.
Hip hip hooray!
हाथ ऊपर करने होगा. जल्दी चलेगा क्या? अंदर नहीं है. अब बढ़िया से ले लो, सबको भेजना होगा, सब लोगों ट्रेड वाले लोग को, वो लोग अपना लगाएगा उसमें.
Thank you, sir.
थैंक यू सर. मिलते रहेंगे. बिल्कुल सर.
ऐसा इनपुट देते रहिएगा कुछ कुछ जरूरत.
हाँ नहीं तो
Thank you very much. Thank you to all the trade delegates for taking participation over here and contributing in this conference. Thank you very much.
कॉन्फ्रेंस तो बहुत होता है, बाकी हम लोगों का